Nirmal sir?
Yeah. Good afternoon.
Good afternoon, sir.
Yeah, we'll just give 2 minutes for all of them to rejoin. Kumar, yaar, IMA prayer, yaar.
Dr. Edilarsi, sir.
Edilarsi, okay. She has joined.
Check. April. Join பண்றாங்க.
Okay.
Video is on.
Good afternoon, sir.
Good afternoon. Sorry, there's some connectivity issue here, so I had to rejoin and then make all of you rejoin. Sorry. Okay, can we start? I think most of us are here. So I made the speakers co-host. You can share your screen. So we'll start the meeting now. So good afternoon, everyone. Welcome to the November CME of IMA Tambaram. So we have a special program today. So let's start as with our tradition. Let's start with IMA prayer. I request Dr. Edilarsi to lead us with the IMA prayer. Dr. Edilarsi, please.
Yes, sir. IMA prayer, live to serve. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Thank you. So indeed, my pleasure to welcome all of you for this afternoon session. So this CME is have 2 sessions. One supported by Novartis. The first talk is by Dr. P.K. Jayachandran, medical oncologist, on the topic how to suspect CML early. And welcome, Dr. Jayachandran. Thank you for joining us. And the second session is to commemorate the World Diabetes Day 2021. And the topic is remission and reversal of type 2 diabetes mellitus. So we have an interesting panel of speakers, panelists, and of course, moderators. So I welcome the speakers, Dr. Mariano Anto Bruno. Thank you, Bruno, for joining us. Dr. Vinod Nathaniel from Trichy. He'll be talking to us about fitness and exercise. Dr. Shivakumar, thanks Shiva for joining. Will be talking to us about intermittent fasting, and Dr. Shivaprakash Srinivasan from SCARF will be talking to us about sleep and stress relief. And this panel will be led by Dr. K. Saktish and Dr. Balaji, our own fitness gurus, and moderated by the dynamic commandos Sri Priya and Edilarsi. So that's the program for today. I welcome the speakers, panelists, moderators, and of course, all the delegates who have joined. So there's a lot of interest for this program, not only from our members, but also members and followers of all the speakers from other branches, as well as some non-doctors and non-medical friends also. So we look forward to an interesting session. So before that, we have some update, and that is the question as well as statement we are going to discuss, whether a diagnosis can be reversed or the disease status can be reversed and what is the winning formula. So some update from us. So congratulations to all our members who won prizes in the last North Zone Fine Arts competition. Dr. Saktish, Dr. Kokilavani, Dr. Rachela Daniel, Dr. Batma, Dr. Moses, and Dr. Batma again, Moses and Quatsita. for winning prizes at the North Zone Fine Arts competition, and also Dr. Raj Shekhar. And one more good news is that Dr. Sudan Kusudas, our member, has been selected as the semi-finalist at the All India IMA cultural program named Sargam. So he'll be representing us, and best wishes Sudan for the final program. And as you all know, the state conference is scheduled on December 11th and 12th. I request members to participate in the state conference scheduled at in Coimbatore at PSG Medical College. Our state council meeting is also scheduled on the same day, and I request all the state council members to join us for the program. There's an interesting academic, political, medical, and the leadership feast at Coimbatore, and also takeover of the new president, Dr. R. Palanisamy, in the conference. So I request all the members to join for the annual event. A lot of activities planned for World Diabetes Day by the National IMA, State IMA, and our branch too. And Pan India, there's a lot of interest in World Diabetes Day. There's going to be a 10-day long program for the World Diabetes Day tomorrow afternoon between 12 to 1. It will be inaugurated by our national president at the IMA headquarters in Delhi. Along with it, there is a host of other functions, the Yuva Leadership Award function, and various activities related to the World Diabetes Day. So a lot of marathon and walkathon conducted by many branches across Pan India. We are also planning, but because of the rain disruption, we couldn't go forward with a proper planning. But there is a cycling rally the fitness group has planned. So many of our members who are free tomorrow morning, please join us from the Outer Ring Road, the bus stand where we started our walkathon, Independence Day walkathon on August 15th. So I request members to join us tomorrow morning around 5:30 p.m. for the cyclothon, so where we can raise some awareness among the public. And it's also my honor and pleasure to inform you about the formation of Election Commission and the Appellate Commission to oversee the organizational activities, elections for the year 2022. So we are happy to pass on our baton to the next team. So whoever takes over the mantle, and so there is a system in place as per our IMA constitution and the Societies Act. So I formed two committees. One election committee led by Dr. T.N. Ravishankar as the chairman, Dr. Kasi and Dr. Ellison sir as the member of election commission. And second is the formation of appellate commission in case there are any issues arising out of elections. Dr. G. Raghavelu will head this appellate commission with members Dr. M. Balasubramaniam and Dr. Ambuda Karnadidi, all past president of IMA Tambram, and as per the constitution, we have formed these two committees, and they will organize, call for nominations, scrutinize the nominations, announce the elections, as well as per the schedule, it will be followed. By 31st October, we plan to conclude the election process and announce the next team. So that is the information to all our members. So with that organizational information, I request the secretary to give his secretary report. Over to you, Dr. Saravana Kumar.
Thank you, sir. Thank you. Thank you for the opportunity, sir. This is in continuation of the secretary's report that I submitted, I presented last month during the last meeting. To recap, on September 11th, we had a CME conducted. The topics were ER surgeons melodrama and neck pain and back pain to improve the improper office ergonomics. And also we conducted a eye donation awareness rally from East Tambram to Dr. NIRMAL Eye Hospital on September. Eye donation pledge was also created and motivated people to donate their eyes. And there was an NHP workshop on September 23rd. The member hospitals participated, around 60 doctors and hospital administrators and paramedics participated. They all got benefited by the training program on infection control practices in hospitals. And also a special invited speaker spoke on labor laws. And there was a panel discussion on role of paramedics and paramedics, administrators and nurses in quality improvement and patient safety. And the month of October, there was IMA TNSB North Zone CME on sleep disorders. It was well conducted by our AMS wing. These are all the pictures. And our president announced, just now announced our winners of the competitions, cultural competitions, and also sports meet. On 17th October, there was a Go Green activity and 50 numbers of trees planted at Rajagir Pakam Park, which was led by our Dr. Captain G. Raghavelu. And there was also a camp conducted for the public on coinciding with the World Diabetes Day celebration on diabetic end organ damage. And the final event was the live program, and the topic was on diabetic end organ damage. And also CME was on the principles of management of small bowel obstruction, and another topic was interesting movement disorders by Dr. Vijay Shankar, as well as Dr. Vimaladithan presented on recent trends in management of breast cancer. The panel discussion went on diabetic end organ damage. Thank you for everyone for patient listening. Also, I request all the members to participate in this election for voting as well as for nomination also. We want young generation and new people to come forwards to take up the mantle of secretaryship, treasurership and presidentship. We request the members to not to hesitate to nominate themselves. Thank you, sir. Over to you, sir.
Thank you, Kumar. And so we'll go on to the academic session. So the first session, I request Dr. Vimaladithan to introduce the speaker and the topic. Dr. Vimaladithan.
Yes. So I'm audible now?
Yes,
Yes.
sir. Yes. Yes, sir.
Please go ahead.
So it's a privilege and happy to introduce our college alumni, Dr. Jayachandran, PK Jayachandran. He is a graduated from our Tanjavur Medical College, and he is done at MD General Medicine in Madurai Medical College, and post-graduation from our prestigious Adayar Cancer Institute. And he had various international experiences. He is a Royal College of Physicians and member of European Society of Medical Oncologists. And his keen special interest is in hemato-oncology and stem cell transplantations. And he has presented various papers, both national and international level, and he had a various publication too. And he is a co-investigator in the various research papers, especially in hemato-oncology. And his keen interest is in hemato-oncology and stem cell transplantation. There are only few people in Tamil Nadu or Chennai itself. His keen particular focus on this. He is one among the in Chennai is focused on hemato-oncology. Welcome you, Dr. Jayachandran, to our IMA Tambaram to give a nice talk about how to suspect a CML in earlier. It's really needed topic. Welcome, Dr. Jayachandran.
Thank you, sir. Thank you very much for the invitation and kind introduction about me. It's always a pleasure to have a alumni or senior of mine introducing me. Thank you, IMA Tambaram and other delegates for having me invited for this lecture. It will be a common topic: how to suspect CML early. I just share my screen. my screen is visible.
Yes, sir.
Put it on full screen mode.
Yes,
I put it on full screen mode. So this is my topic: how to suspect CML early. CML is chronic myeloid leukemia. I'll just give some introduction about the chronic myeloid leukemia. Moving forward, I would be giving some history. This is a basic small history about one patient, which nowadays, previously we used to have a lot of asymptomatic patients. Now, a lot of IT companies around Chennai, we do a lot of them do an annual checkup. One such patient, about 45-year-old male, came with a WBC count of 17,500. Usually all the companies have the company physician or have third-party arrangements. So they had checked him on metabolic investigations and then kept him on follow-up. So after 6 months, the patient presented with left flank pain, increasing tiredness, and then he was had a counts of about 37,000 at the point of time. Spleen was palpable. So that time his cytogenetic analysis showed pH positive. pH is the chromosome which is seen in CML. I'll just explain what is pH chromosome in the subsequent slides for all the general practitioners and also the general physicians and other practitioners, because this is one of the commonest malignancies, commonest blood-related malignancies all around the world. This bone marrow picture also confirmed the status of CML, and he was diagnosed with CML-CP. So we all know that leukemia is, even though it is called blood cancer, it arises from the bone marrow. The bone is abnormal. It starts from the bone marrow and then spreads on to the peripheral blood. So initially, bone marrow is replaced by the neoplastic cells. Either it could be a lymphoblastic leukemia or acute, or it could be an acute myeloid leukemia, or it could be a chronic myeloid leukemia. So usually, most of the time, it affects either the stem cells or the progenitor cells, and in some rare cases, mature cells also can be affected, like the CLL. CLL is a leukemia of mature lymphoid cells. As ALL is a leukemia of immature lymphoid cells, whereas AML is a leukemia of immature myelogenous progenitor cells. And to our topic, CML is a chronic leukemia arising from the one twist here is the aberration in the stem cells, but all the things are mature and semi-mature cells are the malignant cells. The aberration is seen even in the stem cell lineage. CML slightly is different from other things, and it can be either acute or chronic, as I said. And subsequently, this is an ontogeny of the hematopoietic system, how a blast starts differentiating a stem cell level hematocytoblast. It's a sort of a progenitor, prior to progenitor cell, the stem cells. These are multipotent stem cells. From that, this starts the differentiation of proerythroblast, myeloblasts, lymphoblasts, monoblasts, and megakaryoblast. So these aberrancies even occur at the level of hematocytoblast or at the level of myeloblast. And this CML, and slowly each and every has their own differentiations. And we are more concerned about the myeloblast, which has differentiation into basophils, eosinophils, and neutrophils, which subsequently are the malignant cells in CML. So leukemia is about 3% of all cancers in humans, and its incidence is about 5 to 10 cases per 1 lakh population. It varies from region to region. In India, it is on the top 10 of cancers list, and it's about 6th on the list in male cancers. Its accounts of CML, if you look at various age groups and various across all the age groups, it accounts for about 20% of the adult leukemias. So it is 1/5, 1 in 5 adult leukemia would be CML. It is the highest among other leukemias. This is the highest numbers. And very commonly, a lot of general physicians come across. We do get referral only from the general physicians. None of the CML patients directly end up to a cancer institution, to a tertiary cancer center, most of the time it is picked up by the general practitioners and general physicians and various other practitioners, and then being referred to us. It's very important for all the general physicians to know about these leukemias, at least to diagnosis. The median age of diagnosis is about 55 to 60 years. This is in Western data, but Indian data says it's about 45 to 50 years. CML again is slightly rare in the younger population, less than 18 years of age. The incidence is very low as about 2% of the 2 to 3% of the whole number of cancers. Coming on to the incidence of CML, this is a data from Tata Memorial in Mumbai. The median age is 32. As I said, the median age is different in Indian population because various other cancers also have an 10-year younger incidence. Even breast cancer, colon cancer, all the cancers have a 10-year lesser age group at Indian incidence. And if you look at CML, there are three phases. One is the chronic phase, the accelerated phase, and the blast phase. So there's no staging system for CML. It's called phases only required. And most of the time, patients present with the chronic phase. It's about 90% of the patient, the patient is present in the chronic phase. About 7 to 8% in the accelerated phase. About 2 to 3% of the population may present in the front line with blast phase. Most common symptom, as we said, the sinus splenomegaly, and most commonly they have a reduced, they have an increased reduced appetite. Most commonly it's due to the splenomegaly encompassing the stomach. They have early satiety feeling, but even though they have a good appetite, they have early satiety feeling. And the other signs of fatigue, weakness. Sometimes the splenomegaly is quite big, it can cause a dragging pain. And nowadays, due to a lot of checkups, right, routine health checkups, we do see a lot of patients who present asymptomatically. That's about 30%, maybe slightly higher over the time. And coming on to the cause of proliferation, this is the CML is the cancer which was path-breaking. And this is one of the cancers where the total paradigm of cancer therapy and cancer diagnosis was changed. It was diagnosed initially in 1960s that there was a chromosome, there was a routine recurrent abnormality was seen in a lot of patients who are presenting in CML, and they could see this one which has been pointed in the arrow mark. This smaller one chromosome of 22nd chromosome was smaller than the other one. This was recurrently seen and it was called as PH chromosome. And subsequently, they also that there was 9 chromosomes slightly larger. Then, after about a decade later, they could find that there was a chromosomal translocation. There was a balanced chromosomal translocation between the ABL gene in the 9th chromosome and the BCR gene in the 22nd chromosome. So, on the combination, when there was the fusion of the BCR, part of the BCR with the part of the ABL, it had this gene, BCR-ABL gene, led to production of a protein, which is BCR-ABL protein, which had an inherent tyrosine kinase activity. Even without a receptor binding, it had an inherent tyrosine kinase activity so that it caused proliferation of the myeloid cells. So why to suspect CML early? So the life expectancy of CML after the invention or discovery of the imatinib. Imatinib is the first of the kind drug which led to a paradigm shift in the treatment of various other cancers. It is started the era of targeted therapy. So after it was introduced in 2000s, and it was introduced in 2000 in West and 2003 in India, after which the life expectancy of CML went on to match the life expectancy of general population. Once it was a deadly disease, where people will not survive more than 5 years after the diagnosis, it became a disease which is like diabetes or hypertension. Nowadays, whenever I counsel a patient in my clinic, I just say them, this is something like diabetes or hypertension. Don't need to worry, and you just have to take tablets lifelong. That's what usually we counsel the patients. So it is something like a metabolic disease which has the targeted therapy either has totally changed the paradigm shift into the prognosis of patients. This again, as a patient, this is a kind of plot which shows the survival. This is called Kaplan-Meier's plot, and it shows that patients with the younger age group have a very good survival, and patients slightly older age group have a lesser survival because of their own age. In most of the time, CML patients do not die of the CML per se nowadays. They die of various other comorbid conditions. And again, this is a famous slide which showed that how survival has improved over the decades. Initially, the treatment was just then busulfan, hydroxyurea were used in 1980s. Subsequently, interferon were used, and then interferon. Then also they use stem cell transplantation. In various eras, it all was slowly improving. And once the introduction of imatinib, there was a total different shift in the survival of patients. So CML patients can present either with symptoms or they can be asymptomatic. As I said, asymptomatic in most of the cases, it requires a peripheral smear to start with. Peripheral smear will clearly show that there's an increase in when a patient comes with for all the general practitioners, when the patient comes with the increase in TC count, please do get a peripheral smear, which will throw light into a lot of things. Especially if the patient has a CML, you can see a lot of increase in forms, that's immature forms of myelocytes, metamyelocytes, band forms. All these immature, we will not see myeloblasts, but these myelocytes, metamyelocytes, and the band forms are increased. This will give you a clue to what's the diagnosis of CML, even though the patient is asymptomatic. And most of the occasions, they end up having some neutrophilia, but still not to miss a patient. Usually, we always depend upon a manual counting, manual peripheral smear rather than an automated counter. Most of the time, automated counters do not have very precision towards counting the myelocytes, metamyelocytes. Sometimes they may be expressed as monocytes, sometimes they may be expressed as neutrophils. So it cannot, because those automated counters all do counting based on the size and the granularity. So always manual counting is very important. Manual peripheral smear is very important. Nothing can replace human as of now in this situation. And subsequently confirmation by bone marrow karyotyping and a test called BCR, ABL, PCR. I'll come into that later on. And in a patient with symptomatic patient, most commonly I said the symptoms are early satiety, dragging pain, and weakness and fatigue are the most common symptoms we do see come across. And very rarely the patient has very high counts of 2 lakhs or 3 lakhs. We do see signs of lipoglucositis like confusion, cough. Sometimes we see bleeding also. So once you can see a palpable splenomegaly and CBC report with manual counting. It's very important, and confirmation, as I said. Moving on. Again, these are all normal ways. I don't need to go across these things. And in coming on to the diagnosis of CML, as I said, there are 3 phases. One is chronic phase, next is the accelerated phase, and the blast phase. Most of the time, the blast is the very important. Blast is the most immature form of the myeloid cells. We call it the myeloblast. The amount of blast is what we are very much concerned about. If it's less than 10%, sorry for the mistake, it's less than 10%, it's chronic phase. If it's 10 to 30%, it's accelerated phase, and if it's more than 30%, we call it as blast crisis. So blast crisis or blast phase go in hand, there's no difference. We call it differently. And if you have a basophil percentage of more than 20% with blast count less than 30%, still you call it as accelerated phase. Platelets does not come into the classification, but most commonly in blast crisis, platelets are less. And in all the 3 phases, the marrow cellularity will be almost 100%. So we don't see any much of fat in the bone marrow. So coming on to the diagnosis, I showed you this cytogenetics, but nowadays most of the centers do not have karyotyping, and karyotyping is again technically a lot of issues are there, like metaphase growth can be not be there, or there can be issues in analyzing the bone marrow. So most of the time now either FISH or the PCR is being used. FISH tests the FISH is fluorescence in situ hybridization test for the fusion of 922. So if you see a fusion signal here, you can see a fusion signal here, which shows that the BCR and ABL are fused. So this gives an interpretation of BCR ABL positivity. This is one of the tests which is used, and more commonly now uses the PCR. So PCR is the testing of the mRNA. So BCR and ABL fuses in the 9 and 22, which gives rises to a DNA, which is gives rise to mRNA. That mRNA is being tested. So this mRNA is being amplified and tested, so that if this is the most common modality of testing and most swift, you can get the reports within few hours, and most of the labs give it within few days because they pool the tests and then do analysis. So we get the reports within 2 days. Any lab, standard lab in any city gives the test reports in 3 days max. That's what is usually happening. This is the commonest modality of testing used as of now. We call it as BCR, ABL, qualitative RT-PCR. So this comes on to the sensitivity of what I was explaining about. So hematological is very broad-based diagnosis, after which comes the karyotyping, where again I told technical difficulties, and subsequently in karyotyping you see only 20 metaphases, whereas in BCR ABL FISH you see about 200 cells, so minimum 200 cells to be counted, so that you have more precision. And in molecular PCR testing, it is a totally different sensitivity. It can even sense a very small amount of cells. It is what we use for in the sense after starting the treatment for reassessment. Nowadays we use only molecular testings for reassessment of a patient with a CML who is on treatment. So without treatment, what happens? This rarely happens as of now, but without treatment, a patient with chronic phase can last for in the same phase with 4 to 6 years, after which he progresses on to accelerated phase. Subsequently, about a year after, he progresses on to last phase. But it never happens in this era. These all data comes from the era when there was no treatment at all, only palliative treatment was present. So at that point of time, this was a real situation. As of now, a diagnosis of chronic phase with TKI will go on to live for his normal life, which is expected. So again, CML has excellent treatment available. We have a lot of TKIs like imatinib, nilotinib, dasatinib, bosutinib, all available. Previously, about 2 years ago, only imatinib was available, and other two TKIs, nilotinib and dasatinib, also available. Slowly came into picture. It started 2003. Imatinib was introduced in India. Nilotinib was introduced in 2012, and dasatinib was also introduced in 2012 in India. Subsequently, everything except imatinib was very costly. Now we have all the 4 TKIs. That's what I was telling: imatinib, nilotinib, dasatinib, and bosutinib, which are all the 4 are being approved in first-line therapy in CML, CP, and all of them are available at an affordable price, less than 10,000 rupees per month is what all the 4 drugs are available at the cost. So now therapy to patients is not an issue. The availability of drug to patients is not at all an issue. So it's very important to diagnose at a proper time and refer the patient at a proper person to carry out the treatment. So as I said, they have a near normal life expectancy. And if you have a patient diagnosed late in the AP or last phase, the survival expectancy will be slightly lesser than what is expected. If the patient is diagnosed in blast phase, the patient would additionally require stem cell transplantation, and also the survival is poor when compared to patient being diagnosed in a chronic phase. So there are a few criteria which we look into it. This is hematological criteria, cytogenicity criteria, and the molecular criteria. And we most commonly, as we test for molecular transcripts now, so we usually use the molecular criteria for response assessment. So earlier on, when there was no drugs, just palliation, you just reduce the symptoms of the patient. If you achieve a complete hematologic response, it was a very great achievement at that point of time. After then, slowly, a molecular cytogenic response, a major cytogenic response was introduced when the hydroxyurea and intravascular was used. That itself was very great achievement. When in 2000s, when imatinib was used, slowly the response assessment was by MMR, and now deep molecular response is what we require as an additional on the top of MMR. MMR's major molecular response, which is defined as less than 0.1% BCR, which means that about when we test about 1,000 cells, less than a cell is positive for CML. So this is the depth of response. Slowly, when we see that, we assume that all patients have all the cells positive at diagnosis, and at the end of 1%, 0.1%, 0.01%, now we have even tests to diagnose 0.001% sensitivity also. Our institute has even tests to diagnose that level of sensitivity. We call it complete cytogenic response when there's 2 log reduction from 100 to 1%. And we call it major molecular response when there's 3 log reduction from the upfront. And it is almost called undetectable if less than 0.001. But our sensitivity is not that much up to sense it less than that. Just on these things. Something called early molecular response we expect nowadays, that is at the end of 3 months, the BCR must be less than 10%. Such patients do very well compared to patients who do not achieve the 10% at 3 months. So this is what I have showed in the other pictorial representation of how much we test, how small amount of cells also we can able to test in the patient. So again, the outcomes. Again, as I said, this was one I was alluding to in the previous slide. That this patient achieves BCR of less than 10% at 3 months, the survival will be about almost equal, very good. If they don't achieve BCR at 3 months, there's something wrong in such patients. We need to further evaluate on various other investigations we usually do. We look for additional chromosomal abnormalities. We look for something called as imatinib resistant mutation analysis, and see why it is not working properly, and then do change the PKI or do something else better to the patient. In such patients whom the BCR is going to be less than 10% at 3 months, the survival is way different from what is going to be at 3 months. So I'll come on to this, what usually we use as a response assessment criteria. At 3 months, the optimal thing is what BCR of less than 10%. At 6 months, it is less than 1%. And after 12 months, at any point of time, you expect a BCR of less than 0.1% is an ideal amount of BCR accepted. And a failure at the 3 months and 6 months is more than 10%. You call it as failure, and you do investigate, you do repeat bone marrow, and investigate why it is not, why the disease is resistant, and act upon it. You go for second line therapy, third line therapy, and if not, if a patient is having a stem cell match, then you can do a stem cell transplantation. At 12 months, if the patient doesn't achieve 1%, then it is also a failure. And any point of time the patient loses a 1%, more than 1%, or if any mutations or resistance then it's a failure. So slowly we are moving on to something called as treatment-free remission, that is operational cure. It is something which is in very early, it's an early data is present. That's what in patients who are on long-term treatment for CML for about 10 years or more of CML, and who have an excellent response, like more than deep molecular response, which was I was telling, is BMR 4.5. It's 4.5 log reduction from initial point of the therapy. If that amount of remission is maintained for more than 3 or 4 years, and the total treatment is for more than 8 to 10 years, are trials, clinical trials who had stopped imatinib or TKIs in such patients, and in patients whom they have stopped, in about 50% of the patients, the disease has not come back. So there are various immunological data and various immunity, innate immunity of the patient all been hypothesized and postulated as a theory began why the disease doesn't come back. So as of now, our operational there is chance for operational cure that in a very long treatment patients we can even stop the imatinib, and maybe about half of the patients may go into state. And very important is in patients whom quality of life is affected. Very few patients, about 2 to 3% of the patients may have very bad adverse events due to these TKIs. These TKIs are fairly tolerated very well across the board. So in such patients, we may need to stop it at some point of time, after a long time. And long-term effects of therapy for imatinib is very well known. There's no long-term effects. As for newer TKIs like nilotinib, dasatinib, and bosutinib, they still need more longer data. We have only 10-year data. We don't know about 20 years, 30 years taking this about what will happen over time. Imatinib, we have about 25 years of data as of now to how it does. There's no long-term side effects. And cost, I said, it has come down significantly low. And most of the insurance schemes supports all the drugs in this armamentarium. Thank you. I will be happy to answer any questions related to CML or may outside CML also is fine.
Thank you, Dr. Jayachandran. So any question from the audience, you can unmute yourself. Dr. Vimal.
Excuse me. Will
Yes,
the total
kindly
count,
identify yourself and ask your question, please.
I am Dr. Rukmani.
Yes,
I would like to ask whether in CBC always the total count is increased or it can be normal also.
Yes, ma'am. In CBC will be always in a CML patient. We expect always a CBC, the WBC count will be increased. There will be no patient with normal CBC and having a CML. It is not possible at all. In CML patients, you will always have a increased WBC count. You can have a patient, such patient, but we never have come across. Hypothetically, if a patient undergoes a bone marrow for no reason, that it can happen, but it won't have. In a clinical practice, in a patient with higher WBC count, only we can suspect CML.
Okay, thank you.
As for acute leukemias, what you said holds good, madam. Sometimes patient can even have normal blood count or even low blood counts. Still, patient can have ALL or AML. But for CML sake, it is not possible.
Okay. Okay, thank you. Thank you.
Okay. Any further questions? Okay. So thank you, Dr. Jayachandran. I think there are no other questions or queries on your topic. Kindly stay with us. If there are any questions in the chat box, you can answer them directly.
Sure. Okay.
And
sir. Thank you very much for the invitation, sir.
Thanks for the wonderful lecture. It was really nice to hear that. So previously, when we started our medical curriculum, the moment we diagnosed this leukemia, the prognosis was bad, and the movies also made things worse. That many of these patients were looked upon as end stage, and they were not even considered for treatment. We're glad to know that science has progressed so much, and we are able to give good remission and also good quality of life during that period. And also many of the leukemias can be reversed. So thank you so much for
thank you, sir.
Coming out with wonderful presentation.
Thank you.
We'll move on to the next topic, next session. So that is a panel discussion as well as talks on this important topic, whether we can reverse or remission is possible. Similar to leukemia, diabetes was once upon a time looked as a difficult disease to treat. And our patients, when we say they have diabetes, the reaction ranges from just shrugging of shoulders to angry reaction and to depressed crying, and the whole thing become messy in our consultation rooms. So it's a varied reaction to a diagnosis of diabetes. And particularly specialists like us, when we inform the patient that you already have complications with reference to diabetes and towards end stage or end organ damage, it's really difficult to convince them to take care of the diabetes or take care of the complications. So there is always a missing link between and what we diagnose medically, tell them, and there's always a gap between our medical doctor's prescription or education or counseling, and there is a huge gap between patient understanding and their perspective. There's a lot of things to it, the affordability, the accessibility to the care, and also the advanced therapeutic actions. So to bridge this gap, so let me put some basic information before right. As you see that there's a bridge work in progress. You can see a lot of missing links, and you all know that it's quite unsafe at this stage. But of course, once the bridge is completed, the entire landscape changes. There's a beautiful bridge with a good landscape, good viewing, and it makes things easy for many people surrounding that area. The same way in diabetes, what we are seeing is a lot of missing links between our treatment and also the patient perception. And these are the data. So in 2019, 77 million with people with diabetes, and in another 10 years, it's going to be 100 million disease, and of course involving 100 and many billions in the market economics. And by 2045, 134, where we'll beat China and will become the diabetes capital. So these are the huge data, and with national prevalence of diabetes 8.9. So this is more than a pandemic, what we are going to face. So, and this is the problem statement, and not only retinopathy, even all the end organ damage is going to increase as the longevity of disease is going to be there. And by 2040, these are the data in red predicted by the national organizations. And we do have a pyramid of healthcare system in India, but the data and the numbers with our population, there's a huge challenge. And we all know the bigger the challenge, the bigger the opportunity. And so we have a lot of leadership issues, resource issues like investment, the care issues, not only the medical part, but also the preventive part, and also have to keep on engaging the community on a larger scale. So the civil society as well as the medical society has a larger role, and that is where IMA has come into the picture. And you all know the spectrum of disease, right, from awareness to prevention, screening, early diagnosis, and treatment of concurrent systemic disease. It takes a whole lot of the medical establishment to treat these patients. And to create awareness, 100 years back, we all know insulin was discovered by Banting and FREDRICK. And tomorrow we'll be celebrating that 100 years. So 14th November is the World Diabetes Day. And many organizations, including the government and Indian Medical Associations, taking this day as a serious awareness month on diabetes mellitus. And IMA has come to together with NPCB, All India Ophthalmic Society, Association of Physicians of India, various diabetologists associations, to create awareness as well as put our heads together and to find out some solutions. And this is the entire program for the IMA national body from November 15th on various topics, and tomorrow it will be inaugurated. So 15th, diabetes and COVID, diabetes and hypertension, and then brain and diabetes. And then we have the scientific research paper presentation. On November 20th, diabetes and eye. And 21st, we again have a session on diabetes and lifestyle modification at the national level, diabetes and kidney on the next day, and then diabetic foot care. So there's a 10-day long program, not only by the IMA headquarters, but also state has similar program going on till November. So I urge all of you to please join in this initiative, and I'm part of this National Standing Committee on Prevention of Diabetic Blindness as well as the National Conclave. So our job is to take this initiative and see how we can coordinate and collaborate with other stakeholders, including the government, frame certain policies and guidelines, strengthen the state and branch level teams, and also get data and form a diabetic registry so that we can scale up this initiative, and together we can do wonders at the national level. So as part of this initiative, we wanted to do this topic on whether a diagnosis or the state of diabetes be reversed. And there are certain key answers and research paper that it can be reversed by adopting a winning formula. And the next 1 hour or so, we'll be discussing this, what this winning formula is about. Can diabetes be reversed? There is a question foremost among many of us, as many doctors also are diabetic, either in the pre-diabetic stage or undiagnosed stage, or already having diabetes yet to diagnose with the complications or some part of complications. There are a lot of research papers and books available, and there are various programs, some authentic allopathic programs, some non-allopathic programs, and this is actually a big money spinner nowadays, reversing diabetes in particular days, like language programs. And there are authentic programs and books on reversing and having life without diabetes. And preventing the diabetes burden, yes, we have a major role at the prevention stage itself. And that is the reason why we have this experienced panelists today. And this is also our motive of our branch when we took over, that we'll take care of doctors' health, because we know health is wealth. And the last 1.5 years or so, we have initiated various fitness activities, and also have put a fitness, sports and fitness committee in place to take care of the initiatives for our branch members. We did organize marathons, walkathons, various cycling activities, and also group challenges. And I think the 5th challenges is in the planning. Hopefully, once the rain issue subsides, our team would be able to announce this. And more than all these things, getting together people so that this mental health is also taken care of. So once you take care of your physical health, automatically the mental health improves. And once you take care of the mental health, the holistic health improves, and thereby our wealth also improves. So this program is all about reversing your diabetes. What are the methodologies? To this end, we have a wonderful panel. I'm sure our moderators will introduce them. I know them personally. They not only preach this topic, they practice and also help others to find solutions and also follow their methodologies and whatever things they have to tell. So I'm happy to invite Dr. Bruno, Dr. Shivakumar, Dr. Vinod Nathaniel, and Dr. Shiva Prakash, all of them experts in their own right in this particular field, and invite our moderators to take charge, the dynamic secretary of our IMA fitness committees, and also Dr. Sri Priya. Thank you so much.
Thank you, sir.
Over to you.
Thank you, sir. அனைவருக்கும் பிற்பகல் வணக்கம். On behalf of the Sports and Fitness Committee of IMA Tambaram, I am very happy to invite you all for this CME session in connection with the World Diabetes Day. In today's session, we'll have 2 short presentations followed by the panel discussion. So we'll start the session right away. Over to you, Sri Priya.
Are you able to share your screen?
Yes, I'm doing now, sir.
Yeah. Okay.
Sri Priya.
Can you see my screen, Edith?
Yes. Make it slideshow.
Shall I share it for you, Sri?
Yeah, I think I'm sharing it.
Okay.
Very good evening to you all. Myself, Dr. Sri Priya. I welcome you all for this interesting session of today's meeting. We have a panel discussion now on nutritional facts, diet plan, fitness, stress and sleep disorders. We have here with us experts from various fields for a panel discussion. Before the discussion, we have two short presentations on keto and low-carb, high-fat diet by Dr. Mariano Antobruno, followed by presentation on intermittent fasting by Dr. Shivakumar. Dr. Mariano Antobruno is a neurosurgeon. He is India's foremost expert of diet-based interventions for non-communicable diseases. He has authored a book called Science and Psychology of Paleo Diet, which was the winner in Amazon Pen to Publish competition in 2019. He did his MBBS at Tirunelveli Medical College and won gold medal in MBBS. He has also won KK Bizaria Award for Best Paper in Allied Neurosciences All India level during his MCH neurosurgery. He was Nodal Officer, Tamil Nadu Accident and Emergency Care Initiative, Department of Health and Family Welfare, Government of India between 2017 and 2019. He was Nodal Officer for Health Management Information System, Government of Tamil Nadu, and was awarded Certificate of Appreciation by the Government of Tamil Nadu for developing web-based monitoring interface. He has written 11 medical books and also written 10 books in Tamil. I welcome Dr. Mariano Antobruno. I now request Sir to start his presentation. Over to you, sir.
Yeah, thanks for the warm introduction, madam. Let me share the screen. Is it clear? Are you able to?
Yes, Bruno.
Yeah, you are able to hear me?
Yes, very much.
We'll go. So this will be a very short presentation, and we'll be talking on seeing few points about diabetes and few points about the keto diet, and then what gets reversed in the keto diet, and what are the advantages of this LCHF or keto diet, the disadvantages, and then we can go for discussion. So type 2 diabetes, okay, there are lots of discussions, already Sir has told it. So basically the main problem in type 2 diabetes is there is a low glucose inside few cells and high glucose in blood. Why I mean few cells is there are certain cells which get glucose even without insulin, but there are certain cells which require glucose, which require insulin for glucose transport. So essentially, the problems in diabetes is not just a high glucose outside the cells, but also low glucose inside most of the cells. And why this happens is because of less insulin in blood. And the less insulin can be due to a more insulin being used by fat tissues, or whether there is less insulin getting released. The less insulin getting released can be again due to two causes. It can be due to less insulin being produced, or there is an insulin being produced, but there is some problem in the release. And why should we treat diabetes? Because if untreated, the high blood glucose can produce lots of complications, which we can see it as either as an acute effect or a chronic effect. Acute means short-term effects, chronic means long-term effect. The short-term effects can be the diabetes ketoacidosis or hyperosmolar hyperglycemic syndrome, and the long-term effects are classified as vascular and non-vascular. And by vascular, we have both microvascular as well as macrovascular. Retinopathy, neuropathy, and nephropathy are microvascular complications, whereas coronary artery disease, cerebrovascular disease, and peripheral arterial disease are macrovascular complications. So essentially, if you see the spectrum of diabetes, it leads to an increased blood sugar, it leads to decreased sugar inside the cells, it leads to a risk of decay and HSS, and leads to the complications. Now, let us come to the LCHF diet. Basically, there are lots of diets under the category low carb, high fat. Okay, keto, paleo, Atkins, Mediterranean. There are lots and lots of names, but essentially the biochemistry is same. It is just like having a two-wheeler with various brand names, but essentially you have a 2-stroke or 4-stroke engine, 2 wheels, as a gearbox and a chain. This is also like that only. So what do you mean by a low carb diet is we reduce the following. We reduce sugar, honey, jaggery, palm sugar, rice, wheat, maida, millets, oats, and corn, potato, sweet potato, tapioca, yam, fruits. So chini, ten, natu chakra, achuvello, everything. And the most important point we need to remember at this slide is that both rice as well as wheat cause hyperglycemia. That it is not that rice is bad, wheat is good, or it is not that sugar, refined sugar is bad, whereas jaggery is good. Everything increases the blood sugar levels. And now the next question is, okay, you want to reduce all this. How much you want to reduce? My advice will be always as much as possible. I'll explain this later. And the next question is, okay, we are ready to reduce the carb intake, but we will not take more fat. The very simple point is, if you construct a 2x2 matrix with low fat, high fat, and low carb and high carb, whether you are taking low fat or whether you are taking high fat, when you take high carb, you get both obesity as well as hyperglycemia. Your hyperglycemia is not related to your fat intake at all. Whether you are taking low fat or high fat, you still get hyperglycemia and you still get obesity and all the complications. Whereas when you are taking low fat carb, if you are not substituting the calories with fat, you end up with something called a starvation. Okay, that is not a diet, it is starvation or fasting. So let us not do that. We need to give the adequate calories, but we are just changing the source of calories from carbs to fat. So this is the difference between a low carb, high fat diet, keto diet, and starvation. So we don't want to be like the Vikram in the side picture. We want to be like the Vikram in this picture. Okay. Now coming to the very often asked question, this diet is reversed. Okay. Now, what do you call it as reversal? How do you define reversal? Varies from person to person, varies from hospital to hospital, varies from country to country. But what I can categorically say is that if the earlier diabetes or hyperglycemia was due to an extremely high carb diet, which is the fact in Tamil Nadu, most people in Tamil Nadu, most people in South India get diabetes because the carbohydrate is proportionally very higher in their diet. If the diabetes had been due to a high carb diet, it will be reversed when you take a low carb diet. And if your diabetes or hyperglycemia is due to obesity, it will be reversed. If your diabetes or hyperglycemia is due to an insulin resistance consequent to obesity, that also will be reversed. If your diabetes or hyperglycemia is due to your beta cell fatigue, that also will be reversed. And diabetes or hyperglycemia due to other reasons may not be reversed. So this is a very point we have to be very, very careful. Not all types of diabetes, not all amplitudes of hyperglycemia can be totally reversed. But again, the most important point is, irrespective of the type of diabetes, irrespective of the fasting blood sugar, when you take a low carb diet, your requirement for your anti-diabetic drugs and your requirement for insulin comes down. So there should not be any. So I think the first question to be asked is whether the requirement for drug comes down, and if the initial requirement is less, it is you don't need a drug, and you can call that it as reversal. So the advantages of LCHF diet are, first, it reduces the need of drugs, and if the need is less, you can stop. Then it reduces the amount of fat in the body, and because the amount of fat in the body is reduced, the insulin which is consumed by the fat is reduced, and hence more insulin is available for tissues. Insulin resistance is reduced, and this can also produce a reversal of diabetes. And whether you are reversing the diabetes per se or not, you prevent the acute complications of hyperglycemia like DKA and HSS. And you can reverse the chronic complications of increased blood sugar like retinopathy, neuropathy, nephropathy, CAD, CVD, PAD. Again, there is a rider here. When I say reversed, the end-stage nephropathy, end-stage neuropathy don't get reversed. If the complications, if the microvascular and macrovascular complications are in the earlier stages, they get reversed with the LCHF diet. So I am summing it up. So the diabetes due to certain causes are reversed. The risk of DKA HSS is mitigated, and complications in earlier stages are reversed. Now, okay, if the low carb diet is so good, why people are not taking? Because it comes with its disadvantages. All roses come with thorns. Only paper roses don't have thorns. Same way, any treatment method you follow has its own share of disadvantages, risks, complications. This also has it. So the disadvantages can be classified as to high fat, high protein, or low fiber. So what happens when you are giving a high fat to a person? So far, the person was getting 80% of his calories from carb, 10% from fat, and 10% from protein. Suddenly, you are reducing the carb and increasing the fat. Two things can happen. Okay, if the person's fat metabolism is normal, the LDL does not increase and there is no problem. But however, there exists around 10 to 15% of people who have some inborn errors of metabolism in the lipoprotein pathway, and for them, the LDL and consequently the triglycerides and total cholesterol rapidly increases, and it is where the problem starts. So the problem is when the LDL increases, it is an independent risk factor for the macrovascular complications. So what happens is you are reducing the macrovascular complications caused by hyperglycemia, but the macrovascular complications caused by hypercholesterolemia are augmented when LDL is increased. However, the solution for this is very, very simple. Please take statins or whatever drug you like. And you can, if you ask me what is the dose of statins needed, the answer is the dose which is needed to bring the LDL to the normal level. Why I am saying this is, there are some people who say LDL 130 is normal, some people who say LDL 100 is normal, some people say LDL 150 is normal. Let us not go into the individual preferences. The point is, whatever you consider as the normal LDL cutoff level, you maintain that with statins or multivitamins or whatever drugs, and make sure that the LDL level does not increase during a low carb, high fat diet, because allowing the LDL to increase during a keto diet mitigates the few advantages of the diet. So what happens with a high protein diet? As any high protein diet produces a strain on the kidney, and if the person already has a deranged glomerular function due to any of the reasons, that can be there are hundreds of causes for kidney failure other than diabetes. So it can be any of the congenital syndromes or any of the glomerulonephritis, nephrotic syndrome, whatever be the causes. If there is some other insult to the kidney, where the kidney function is already not on an optimal level, overloading the kidney with the high protein may cause some problem. Again, it is easy to solve. Reduce proteins, example meat, and increase the fat. And take a keto diet or LCHF diet only if the nephrologist agrees. The next set of complications can be the ones which happen with low fiber like constipation, and it is very easy to solve. Take plenty of water, take butter or cheese, or take 1.5 liters in the water in the morning to activate the gastrocolic reflex. Many people actually, they stop LCHF diet because they don't start it in a scientific manner. They think that eating half a kg chicken is a keto diet. They eat too much of non-veg, too less of fiber. And if they had already some piles, fissure, fistula, that gets aggravated and they quit the diet. That's not the problem. You can just follow simple techniques to mitigate it. Then the other complication can be, there will be sudden fall in iron levels. Because what actually happens when you change from a low carb, high carb diet to low carb diet is, you are changing the metabolism of the cells. So lots and lots of new enzymes are synthesis, lots and lots of coenzymes are synthesis. So this leads to a transient vitamin deficiency and a transient iron deficiency, which can be managed with supplements. So is there a diet chart? Okay, my opinion is that this diet chart is for unscientific people or some paramedics. As far as doctors are concerned, you just need to understand the concepts and reduce the sugar, honey, jaggery, palm sugar, rice, wheat, maida, millets, oats, corn, potato, sweet potato, tapioca, yam, fruits. Just reduce this, most of the benefits will be obtainable. So take home message is, LCHF reduces, reverses a few types of diabetes, not all. LCHF reduces, reverses, but all of the complications of diabetes. And this has to be followed in addition to drugs, exercises, lifestyle modification. This is not a magic pill. And this is not an anti-drug, anti-insulin or anti-statin method. This is one part of the treatment for diabetes, and this does not replace any other part of treatment. Maybe if it can reduce the requirement for insulin and drugs, and there is no need to stop any drugs when you are following LCHF diet. And if there is a high LDL, high urea, high creatinine, or any high amylase, high lipase, whatever, if it is high or low, appropriate medical management has to be done. And it is a scientific diet when done in a scientific manner. I have written 2 books on this, one in Tamil and one in English. Those who are interested can read it. It is not big book. Maybe it will take less than an hour to read, but it gives all the concepts clearly. So I think I have not exceeded the time and I have conveyed the message. The rest we can discuss during the panel discussions.
Thank you so much, Dr. Bruno. And that was a very short and clear presentation. Please do stay with us. We'll be having question session at the end. The next speaker is Dr. Shivakumar, and he'll be talking about intermittent fasting. May I request Dr. Balaji to introduce Dr. Shivakumar.
Am I audible?
Yes, sir.
Yes. Yeah. Can I have the slide, please? Yeah. Yeah, I know Dr. Shivakumar from a long time, so I thought I will just do a brief introduction. He did his MBBS at MMC in 85 to 91 batch, DO at Stanley Medical College, And he's been a consultant ophthalmologist at Sri Sarada Eye Clinic and Dr. Mohan's Diabetes Specialty Center. He has definitely been following the low carb and the fasting lifestyle since 2017. And I know personally that he has done a lot of extended fast of 3, 5, 7, 10 days. And I think right now he's on a fast. He'll tell you about it. And he has definitely done for 12.5 days when he was regularly sharing the data with us. He is somebody, when he is somebody who inspired me to do fasting and start this lifestyle. Because I remember one day, I think at 2018 end or something, when I was talking to him something about weight, and I casually mentioned in a very, in fact, I was laughing when I mentioned this, told him that, sir, people are eating fat to lose weight. It's crazy. I don't know what they will do later. And then he was not laughing with me. And then he told me, Balaji, have you tried it? Have you read about it? And he said, I have been doing it for the past 1 year and definitely I have been having results. He's He's somebody who doesn't do things lightly. That is, he's a very famous ghost surgeon for a lot of surgeons in the city. And he used to come with his own pack of managing complications, all the viscosurgical devices, everything together. So he's very well prepared to handle everything. And if he's going to talk on a topic, he would have definitely investigated it, thought about it, made sure everything is in order before he follows. So I was inspired to try his method and it definitely works. And I will now let you address him itself. Sir, please start. Thank you.
Am I audible?
Yes, sir. Yes, sir.
Yes, sir.
First of all, at the outset, I would like to thank IMA Tambaram, especially Dr. NIRMAL and Balaji and other team members. I don't have any financial interest in any of the products I'm going to mention in my discussion. And I'm not a qualified or an expert endocrinologist, but I'm a regular routine eye specialist who is learning about food, nutrition, exercise, and fasting to improve my own health. If you do a Google search on intermittent fasting, and you'll have all sort of things, 5:2, 8 hour, 12 hour, so many things will be there, alternate day fasting, everything will be there. But according to our medical fraternity, it's a recent article in New England Journal of Medicine, it's a review article, 2019. According to this article, intermittent fasting can be classified as a daily time restricted eating and 5 to intermittent fasting and alternate day fasting. Beyond this, all comes under the extended fasting. And every one of us are interested in daily intermittent fasting. I will restrict my discussion only to the time restricted eating, daily time restricted eating. The recent October 15, 2021, Oxford University has published this very big review article on behalf of Endocrine Society. Title is Time Restricted Eating, that is the intermittent fasting for the prevention and management of metabolic diseases, not only diabetes, for all metabolic diseases. According to this article, the authors defining what is intermittent fasting or a time restricted eating. If you take a daily calorie, it is not the reduced calorie, it's a required daily calorie in a particular restricted window of the hours. Approximately, they mention it 8 to 10 hours. Is there any human clinical trials? Because most of the time when I say intermittent fasting, people ask, what is the data? What is the data you say? But these human clinical trials have been started in the year of 2013 to 2015. And for the last 2 years, there are 160 trials are there. And a large number of ongoing trials are going on. And in this article, authors have selected 39 studies for this review. And why should we do the intermittent fasting or time restricted eating? If you see this graph, this is 10-hour eating pattern. If you do a 10-hour eating pattern and almost 14 hours fasting, you reduce obesity, reduce the cardiometabolic disease, reduce the liver disease, and increase the sleep and quality of life. So for these purposes, every one of us can try intermittent fasting. And the next question comes, when to do? There are generally there's early time restricted eating, late time restricted eating. That is, early means you take breakfast and lunch approximately, and if it is a late intermittent fasting means if you take lunch and dinner, they do like that. And then some people they center the eating period around noon. But according to these authors, they are trying to say if you adjust your eating pattern according to your sleep pattern, because the sleep pattern is a central circadian clock. The eating pattern is a peripheral circadian clock. So if you adjust according to this sleeping pattern, you'll have a more benefit. It's recommended is if you start your eating window just 1 hour after wake up, and you should finish eating 2 to 3 hours before eating. And approximately you try to do 8 to 10 hours of fasting. That is more beneficial. And how many hours we have to do? The total studies have studied between 4 hours the minimum eating period. It's the eating period, and the maximum eating period of 12 hours. But most of the studies, approximately 30 studies, have measured only from 8 to 10 hours. And how long one should do? But for this answer, the studies are done maximum of only 4 to 12 weeks because of the practical problems. But as far as I am concerned, I think you should do it as a lifestyle. And what all the people can do the intermittent fasting. Here, if you see the studies, 18 studies included obesity and overweight people, and 7 studies have done with the healthy adults, and 5 studies done with the active and professional athletes, and 2 studies even done with the older population. There are 4 studies done with the people with the cardiometabolic disease. Out of that, 1 study is done with the type 2 diabetes, 1 study done with the pre-diabetes, 1 study done with the metabolic disease, 1 study done with the metabolic disease with the medication. So what are all the results of all these studies, and what are all the inferences from this review article? Out of 39, 24 studies have got the outcome in reduction in weight by reducing fat. That is the most important thing, and weight circumferences, and reduction in the BMI. And in these 6 studies, there is a energy intake reduction, that is calorie restriction. Intentionally they don't do the calorie restriction, but because of the time restriction, people are able to reduce the calorie intake. This one additional outcome for the intermittent fasting or the time restricted eating. And 12 studies reporting there's a good glycemic control by reduction in the fasting blood glucose, reduction in the glucose under area curve. It is done with the CGM. And that is because of by these things are happening because of the increased insulin sensitivity and increased beta cell function. And 1 study particularly done for the PCOS, in this people observed weight reduction, improved glycemic control with a reduction in the lipid and inflammation. What are all the benefits of intermittent fasting? If we have this list goes on very well. You can see the Alzheimer's, strokes, sleep disorders, obesity, glucose intolerance, pre-diabetes, type diabetes, gestational diabetes also they mentioned, but I don't know how they are going to do with the intermittent fast gestational diabetes, and metabolic syndrome, hyperlipidemia, cardiac dysfunction, chronic disease. From shift workers also I think it helps. And non-alcoholic fatty liver, the most common one, and infertility, polycystic ovarian disease, and some other things, even I don't know whether this all helping or not. And though they have a lot of benefits, there's a limitations of these studies because all these studies are having very small sample size, and it's all done with a very short term, maximum up to 12 weeks. It's done on a single sex, and only 14 randomized control trials are available. And one would know what's happening during the fasting period or the time restricted eating period. After eating up to 3 hours, your food will be broken down into glucose, amino acid, and fatty acid. By the time this leptin will increase, ghrelin will reduce. Ghrelin is a hunger hormone, leptin is a satiety hormone. So once you take food, you will have a fullness because of the increased leptin and reduction in the ghrelin. And once this all glucose and amino acids and fatty acids are gone into the stomach, it will be absorbed into the bloodstream, and blood levels of all these things will be increased. Because the blood glucose increasing, the pancreas will increase release the insulin, and the insulin will all know that it will put the glucose into the cell, and then if it is excess, it will store as a glycogen. Still more excess, it will store as a fat. And after 3 hours, you will get a hunger. If you eat again, this same cycle will happen, so that you will get a glycogen fat. Again, if you eat glycogen fat over the basic energy expenditure. But if you don't eat after 3 hours, when you are feeling hunger, your blood glucose will drop. The moment your blood glucose drops, the body is looking for an alternative fuel. What it does, the insulin will be also reduced because there is no blood glucose. But the glucagon will start increase. Because the glucagon increases, the liver glycogen will be tapped, and that will produce a hepatic glucose release to meet the energy expenditure. And once these glycogen storage are exhausted, after that the body will glucagon will tap the fat source, and it will mobilize the energy for the body. How the fat is converted as energy? You see, the free fatty acid will be released from the adipose tissue because you are not eating, because your insulin is low. We all know that insulin is a lipogenic and insulin is an anti-lipolytic. So as long as the insulin is high, your fat will not be reduced. Once the moment the fat is low in the intermittent fasting, say about 12 hours or 14 hours fasting, your fat will be released in the form of free fatty acids that will get into the liver, and that will be converted into a beta hydroxybutyrate and acetoacetate ketone bodies that will come to the circulation, and then these ketone bodies will be utilized by the organs. But initially, when the free fatty acids will be utilized by all other organs, muscle, heart, kidney, every organ except brain. Brain cannot use a free fatty acid. Brain can only use either glucose or ketones. Once there is no glucose energy, the body will keep increasing the ketones. The level increases in the ketone level, blood level, that will cross the blood-brain barrier, that will give a fuel to the brain. And because of these ketone bodies and in the muscle and other organs, that will produce ATP production for the energy, and that will increase the mitochondrial biogenesis and increase autophagy, and this reduces mTOR pathway, and it improves the performance and stress resistance. In the brain, it increases the neuroplasticity. It increases by the BDNF, brain-derived neurotrophic factor signaling. And this important thing with the intermittent fasting is the timeless eating. You get a benefit of metabolic flexibility. What is metabolic flexibility? When you eat, this will produce glucose as a fuel. When you don't eat, the same applies to the exercise also, both as the same pathway. And your once your glycogen is exhausted, your fat will produce ketones, and that will be utilized. So you have a benefit of intermittently changing between ketones and glucose as a fuel. Because of we are using this metabolic flexibility, the long-term adaptations will be increased insulin sensitivity. We are all talking about the diabetes. So increased insulin sensitivity will be there. That's what you have seen in all the studies. And increased heart rate variations, improved metabolism, lipid metabolism, healthy gut microbiome, reduced abdominal fat. That's what the waist circumference reduction, and reduced inflammation and reduced blood pressure. In a long term, you get a resilience and with the disease resistance. And everyone know how to start this intermittent fasting. There's a recommendation by these authors. Month 1, you start 10 hours of feeding. Maybe you can do an early feeding or a late restricted eating 5 days a week. And then second month, you go to 8 hours of eating window 5 days a week. Third month, you can do a 6 hours 5 days a week. Fourth month, that is the ultimate goal, 6 hours in a 7 days a week. Why they are recommending, or I am recommending 6 hours feeding window is because when you eat and stop eating, the moment you stop eating, you're not going to get the fasting because you need 3 hours, 2 to 3 hours to digest all your food. The moment you digest all your food, then only your real fasting starts in your organs. Maybe your mouth, it is fasting. So if you do a 6-hour eating window, your actual fasting starts in the cellular level at after 3 hours. So you are eating for 9 hours. That's why they are recommending 6 hours of eating window, all 7 days. That is the daily intermittent fasting and daily time restricted eating. And while doing these changes, you should always have a food log, food and activity journal, and you should keep just checking the body weight, preferably fat percentage. And don't forget to monitor your glucose and ketones when you are on a fasting. And how do we take this fasting to the public? We should have all doctors to try this intermittent fasting or timeless eating ourselves. Once we are satisfied, we can have a lifestyle change centers where we can have inpatients for 3 to 4 weeks, and then outpatients 2 to 5 days a week, and then we can implement this intermittent fasting with the diet composition exercise programs. So we have seen all the benefits of intermittent fasting and how to do it, how to start, everything we have seen. And what is the American Diabetic Association saying about intermittent fasting? Is it accepting that or not? In 2019, AD has released an article in Diabetes Care for a nutrition therapy for adults with diabetes, pre-diabetes. They have sent a report. In that, they have compared all the normal Mediterranean diet, low-fat diet, high-fat diet, low-carb diet, very low-carb diet, paleo diet, all the diet they have compared, and then they have got some inferences on the diet part. But in that, they have a mention about the intermittent fasting. Even in the diet therapy, nutrition therapy, they have included one paragraph for the intermittent fasting. In this paragraph, what they are telling, 3 studies they are quoting, that is 18 to 20 hours of fasting. There is no improvement in a HbA1c in type 2 diabetes. There's one study, it shows some reduction in the HbA1c, but all these studies are done with say about 4 weeks or 8 weeks, very short duration. To find out the HbA1c, at least you must do 12 weeks. So that may be the limitation, but I interpret in this report. And one study they have mentioned is there is a pre-diabetic. In this, they have done an early time restricted feeding to increase the insulin sensitivity and blood pressure and other things. What they have done is they have asked the patient, pre-diabetic patients, normal weight patients, they've included. They asked that there's a 2 group. One was a 6 hours eating window, another one was a 12 hours eating window. The 6 hours eating window, they've asked them to finish their last meal. There is a dinner before 3 p.m. That is early feeding window, eating window. By doing this, they have come to a conclusion. Early time restricted feeding increases insulin sensitivity in a pre-diabetic, and it also improves the beta cell function and lowers the blood pressure and oxidative stress. And eating in the morning also prevents hunger in the evening. There is no hunger in the evening, and it also improves it may facilitate the weight loss. But most of the people, they have not lost any weight, but they got benefits from the diabetic point of view, pre-diabetic point of view. And is there any study available in type 2 diabetes? I could find only one study, which is the time restricted eating with a feasibility study. It is not really whether they have tried whether the diabetic patients can do a fasting or not. In that, they've asked the patient to eat between 10 a.m. to 7 p.m. and the 9 hours, because 8 to 10 hours is the average. And they've asked them to do it only for 4 weeks. Again, it's a limited, very short period. And because of the short period, they didn't find any effect on the HbA1c. But they've concluded even this time restricted eating or intermittent fasting is achievable and possible, and there is no harm. It is safe in type 2 diabetes. That was the inference of this study. And again, what is the American Diabetic Association says? there is international guidelines for a remission. When do you call a diabetes is a remission or a reversal? They don't use the word called reversal, they say remission. If you see this chart here downstairs, when you use a pharmacotherapy, at least 3 months after cessation of this intervention, that is, if you stop, whatever the reason, if you stop tablets, after 3 months, they should be normal. That's why it should be less than 6.5. That's what they're mentioning. And if you do surgery like bariatric surgery, after 3 months and then after the procedure, and then after 3 months of stopping the pharmacotherapy, that is, some people, they do surgery, they may continue the tablets. So even after stopping the tablets for diabetes, after 3 months, it should be normal. That's why it should be less than 6.5. And in a lifestyle, if you notice very well, in the lifestyle, they say after beginning of 6 months and 3 months after cessation of the pharmacotherapy. Suppose when you are starting a lifestyle modification, if you have some medications, you stop medications, after 3 months, you should do the HbA1c should be maintained at a 6.5. Then only it is called as a remission. But if you look at the lifestyle, there is no cessation, there is no completing. We must all understand that this is the main point. Most of us ask, when can I go back to the normal diet? When can I go back to the normal lifestyle? Here, ADA is recommending at least 6 months after beginning this intervention. They don't say after cessation of this intervention. That means you have to continue for your lifelong. And how do you monitor these patients? Every 3 months minimum, you should do the HbA1c and it should be less than 6.5, or at least once in a year. That's what they're recommending. So ADA now, August 30th, 2021, 3 months back, released this press release saying that we have a remission of diabetes. So this terminology is approved by ADA. And looking with all this evidence of human clinical trials, what I can conclude, time-restricted eating or intermittent fasting is safe and possible for all. And by doing this intermittent fasting, definitely there will be a weight reduction in obese and overweight people by reducing their fat percentage and reducing the waist circumferences and reducing the BMI. And in a pre-diabetic patients, definitely they have a better glycemic control. They'll go back to the non-diabetic range by increasing their insulin sensitivity and increasing the beta cell function. And even in type 2 diabetes, it is possible to do an intermittent fasting, but the caution of word, you should monitor your glucose and ketones and other parameters on a regular basis. Especially my personal opinion is, if somebody is trying to go for an intermittent fasting with the diabetes, you should have a continuous glucose monitoring CGM. Without that, you should not attempt a intermittent fasting or time-restricted eating in a type 2 diabetes patient. And type 1 diabetes, there is no question, no fasting. Thank you very much.
Thank you so much for that wonderful presentation, sir. Over to Sripriya.
I have to stop sharing my screen. I'll stop sharing my screen.
Okay, sir.
Wonderful lecture, Siva. After a long time attending a biochemistry class without sleeping.
Okay. I think I stopped sharing my screen, isn't it? Yeah.
Can you see my screen, Ariel?
Yes.
Yes, thank you, sir. So let's move on to the panel discussion now. Along with Dr. Mariano Antobruno and Dr. Shivakumar, we have here with us Dr. Vinod Nathaniel, Dr. Shivaprakash Srinivasan, Dr. Balaji, and Dr. Shaktish for a panel discussion. I would like to take a few minutes to introduce the panelists to the audience. Dr. Vinod Nathaniel is an ophthalmologist. He finished his MBBS from Annamalai University and MS Ophthalm from Joseph Eye Hospital. He is a certified fitness trainer by ISSA California. He has finished full Ironman distance in 15 hours and 55 minutes. He has completed a 1,000-kilometer ultra triathlon. He has run 187 kilometers in 30 hours. His best half marathon timing is 91 minutes and best full marathon timing is 3 hours and 15 minutes. That's amazing and unbelievable. Welcome, Dr. Vinod. We have Dr. Shivaprakash Srinivasan. He is a child, adolescent, and adult psychiatrist at SCARF. He did his MBBS from Madras Medical College, MD Psychiatry from All India Institute of Medical Sciences, New Delhi. He has undergone training in general psychiatry at New York and training in child and adolescent psychiatry at St. John's at Johns Hopkins Hospital. He is a life member of Indian Psychiatry Society and Indian Association for Child and Adolescent Mental Health. Welcome, sir. Dr. Balaji is an ophthalmologist at Eye Care Hospital, Crompet, Chennai. He did his MBBS from Annamalai University and DO and DNB from Joseph Eye Hospital. He has acquired FRCS Glasgow in 2001 and a fellowship in retinal surgeries in 2003. Dr. Balaji is the right person to be here with a panel discussion because he has been following intermittent fasting since 3 years and has observed and acquired the benefits of intermittent fasting. Welcome, Balaji, sir. We also have Dr. Shaktish. He's a consultant in ENT, head and neck surgery, also snoring and OSA consultant. He's the director of Hopkins ENT Clinic, Chennai. He did his MBBS at Chengalpet Medical College, MS ENT from Upgraded Institute of Otorhinolaryngology, Madras Medical College. He has done his fellowship in Philippine Society of Snoring and OSA. His special interests include snoring and sleep-related disorders and endoscopic ear surgery. He was invited as guest speaker in various national and international conferences. He's a very active member in our TBM Spin Fitness group, and he's a good runner too and inspires many in the group. Welcome, Dr. Shaktish. I now request Dr. Ariel to start the panel discussion. Over to you, Ariel.
Thank you, Sripriya. We go on with round 1 of questions. The first question to Dr. Bruno. Fatty liver is a common ultrasound finding in general population as well as in diabetics. Can we suggest keto diet for such patients? Will keto diet and low carb, high fat diet worsen the fatty change? Dr. Bruno?
Yes, actually, the fat synthesis in body depends upon the amount of carbohydrate you intake. The amount of fat you eat is not what determines the amount of fat being synthesized in the body. When you eat more carb, there is more fat synthesis and less fat degradation. When you eat less carb, there is less fat synthesis. So fatty liver, the ideal diet will be a low carb diet. The diet in your fat is not the same as diet in your blood or the diet in your body. So fatty liver, the diet of choice would be a low carb diet if all other parameters are normal. And to put it in other way, when you take a low carb, high fat diet, you won't develop fatty liver.
Okay, sir. That was so clear. Thank you, sir. Next question to Dr. Sivakumar. Sir, in your presentation, you clearly stated that type 2 diabetes mellitus patient, if they have to go on with intermittent fasting, there is a word of caution and they have to do it with a continuous blood glucose monitoring. Will intermittent fasting cause blood glucose fluctuations in type 2 diabetic patients, sir?
For everyone, it will produce sugar drop in glucose. But for normal people, because they are not on any medication, the body will produce glucose. Gluconeogenesis will be there from the liver. But the patient is on diabetic patient, those on medication, the medication will keep lowering the blood sugar. And if you're not eating, again, there is a concern about the low glucose. That's why I said, don't do intermittent fasting without CGM, patient who's on medication with a diabetes.
Okay, sir.
Sir, one question. What do you usually monitor, sir? When is the last time you fasted and what do you usually monitor while fasting? Sivakumar, sir.
Okay, actually, you're talking about long fasting, extended fasting, which is not related
yes, sir,
to
yes, sir. Yeah, I mean, whichever you're doing.
So normally I do a lot of blood tests before and after fasting, this panel of tests, to experiment myself, not to prove anyone, but to understand my own body. And generally, when I do a long fasting, I do a CGM, and along with that, I check my ketones, blood ketones. I have a CGM machine with the blood ketones. And the last fast is today. I'm doing a continuous fasting. Today is the 10th day. I had my last meal on 3rd of November, just previous day of Deepavali. So I'm on a water fasting. And at this time, I didn't do any sensor. I didn't do any blood test so far. You may be asking why, how do you believe that you are doing a 10 days water fasting or able to talk so much? If the panel allows, I can check my blood sugar and blood ketones in a few minutes. I can show that my blood sugar and blood sugar even are not even tested for last 10 days. So that is number one. Number two, if you want to see my CGM, I have a CGM done in, I think, June last week. I started a 7-day water fast, but on the 4th day, I had to break my fast because me and my wife also started a 7-day water fast, but my wife had a little giddiness. So we both stopped, and then that time I had a CGM. So I can show you the CGM benefit of CGM in a fasting as well as in a fed state. After that, I was taking normal diet 10 days. I was taking a 1 meal a day. And in that, I experimented with the very high carb meal also. If there's a time, I can do these two demonstrations regarding the extended fasting, but it is not related to the intermittent fasting. It is different.
I think at the end we can take up, sir.
Okay. Thank you.
Next question to Dr. Shivaprakash. Sir, we are all very much aware that the diabetes mellitus is on the rise now, and so are the mental health issues. Does stress affect the glycemic control in patients with diabetes, sir?
Absolutely. Thank you for bringing up this important question. And as is very rightly said, there is no health without mental health. So clearly, it's important for all of us to recognize that stress, emotionally stressful situations are also physically stressful. So it's not like when somebody is experiencing emotional stress, it's just happening inside their head. There are physical manifestations we do experience, and there is a peak in cortisol levels, there is hyperglycemia and so on. And it's also important to keep in mind that that particular stress can have knock-on effects on people's behaviors. The commonest thing that we tend to notice, especially in younger population, is something that we call as stress eating, wherein young people, when they tend to get stressed, exam stress, they'll pick up a box of leftover sweets from Deepavali, which you haven't consumed, and it'll be gone in like 5 minutes. No time it's gone. There are periods of time before exams where people tend to consume higher calorie diets, so ice creams, chocolates, and these have definitely a sense of calming for people who take it. But for individuals who do have diabetes, it does have a significant knock-on effects on their glycemic control. Another important thing that we need to keep in mind, which we hopefully will talk about, is sleep. When individuals have stress, obviously it affects their ability to sleep, and this impact on sleep can cause other knock-on behavioral forms effects, like people will experience tiredness. So how do you counteract tiredness? You tend to eat more, you tend to consume higher calorie diets again. So what is clearly noted is that individuals who do have stress tend to focus on higher calorie diet, and we've had a lot of discussion about mixing up different forms of macro and micronutrients to ensure that we do not overdo any one of these things. Similarly, stress needs to be managed, and if we do not manage stress, it is quite likely that the same problems will tend to persist. So we can talk about this in some time. Yeah.
There is a question for Dr. Vinod, the Iron Man. Can diabetics do long distance running? If yes, is there a risk of hypoglycemia during the run? Sir, please unmute yourself.
I'm audible now?
Yeah, yes, Vinod.
Okay. So yes, so diabetics can take up any form of exercise as far as I'm concerned. So it just depends on the amount of blood glucose that they have. So suppose they are borderline and hypoglycemic, then we have to be a little careful in monitoring their blood sugars during the activity. But if they are well under control, then long-term or long duration or endurance activities are recommended for diabetics. We just need to be a little more careful. Maybe you encourage the use of gadgets like Fitbit or Garmin. I think the recent Fitbit also has a way to find out how much blood sugar you have. So these sort of gadgets will also help during endurance activities. And as such, I think diabetics should be exposed to endurance exercise because it also helps to reduce blood glucose, because the initial stress from exercise depletes the glycogen levels. And after that, blood glucose will slowly get utilized. So more endurance exercise is definitely on the better side for diabetics.
Sripriya?
This question is for Dr. Shivaprakash, sir. Sir, can you please share some tips for a good quality sleep in diabetic patients? Because they do have restless leg syndrome, and some drugs like metformin are prone to cause insomnia. So how to overcome this issue? Because a good sleep is always required, and gradually that avoids stress in a patient with diabetes who's already stressed because of increased sugar levels. Can you please enlighten us with some tips here?
Absolutely. So, as you very rightly said, diabetes can have independent effects on individual sleep. At one point of time, diabetes was diagnosed with nocturnal frequency of urination. So, it does interfere with an individual's sleep. And we've just talked about how lack of sleep tends to influence people's choices of foods that they eat. So it's important to keep in mind that in order to have a good sleep when somebody has diabetes, it's also important to make sure that the diabetes is under good control. We are trying to avoid both nocturnal hyperglycemia as well as nocturnal hypoglycemia, because hypoglycemia will be associated with palpitations, features like nocturnal terrors, waking up people in the middle of the night, and so on. So, good diabetes control is something that anyhow all physicians here are used to working on. But if we want to think about ensuring behavioral aspects which helps us maintain good sleep, one of the key things is physical activity, right? And physical activity is important because it not only helps with the glycemic control, but it also produces a physical state wherein body is tired and appropriately prepared for sleep. Now, people tend to do this and say that I will do it after 8 o'clock in the night or 9 o'clock in the night, and they go out for a run. Sometimes that is really not helpful because that in and of itself interferes with an individual's ability to sleep. The next important thing that we really need is an appropriate environment, right? Now, I'm not insisting on creating AC rooms for everyone, given the status of climate change, but an appropriate environment is one wherein the individual is comfortable, there is sufficient darkness, and there is a set pattern. So individuals, and this is especially true when we talk about physicians and surgeons who have to work overnight. So there will be late night calls, there'll be surgeries, and they'll have to get up and go. But if it's possible, sticking to a routine really helps prepare your brain, because sleep is as much biological as it is behavioral. So preparing our brain, setting it into that routine is really important, and making sure that you have a relatively common on time and an off time. The next really important thing in today's day and age is backlit screens. We all have phones which are bigger than our faces. So it's really important to keep in mind that any sort of light tends to stimulate the brain and makes us want to stay awake longer. So it is really important for us to start thinking about, can we gradually withdraw from backlit screens at least half an hour to 45 minutes before sleep? Most of the individuals who work in software and most of the physicians who have been doing teleconsultations, unfortunately, have been sitting in front of the laptop and then just shutting it and wanting to go off to sleep. And it's really not possible. Creating the behaviors helps train the brain. And I'm sure Dr. Vinod, who's an Ironman, can tell you this. Dr. Shivkumar has told his own experiences of how setting that behavioral pattern, it needs small changes starting initially, but being consistent is really important to getting to the point where you are able to do it. And many a time people get stressed about the fact that, oh, I didn't sleep tonight. And it's okay to let people know that, okay, one night is fine. Everybody has a bad night. Everybody has a good night. But let's come back to it tomorrow. One night of missing a sleep or missing a night's sleep is not enough for us to just fall off the bandwagon altogether. And as physicians, it is really our role to motivate individuals to say that one night of a failure is an error. So we can get back, learn from it, and come back tomorrow and try to fix it. So providing that would be really essential.
Thank you, sir. This question is for Dr. Bruno, sir. Sir, is there a risk of hypoglycemia in diabetics who are on keto and low carb, high fat diet, as this diet plan allows only less carbohydrate, and how to avoid the same?
I think Shivkumar sir has already answered this. No, actually, I'll explain it. If the person is not taking any insulin or oral anti-diabetics, there is no risk of hypoglycemia, because the brain can function in ketones. That sir already told. For the rest of the tissues, the glucose 6-phosphate which is coming via gluconeogenesis, the glucose 6-phosphate itself directly enters the glycolysis and proceeds to TCA cycle. So from fat, even without a full gluconeogenesis, the body gets the anaerobic metabolism going on. So unless the individual has taken a pill or insulin or has some rare conditions like islet cell tumor, there is no chance of a hypoglycemia with low carb diet. And I will add it to one point also. If you have seen, human body for 2 lakh years consumed fat as the main source of calories. Only after agriculture came, we started to eat carb. So our metabolism is more tuned towards a high fat diet, and that's the only reason you have only one hormone in your body which reduces your blood sugar. All other hormones in your body increase the blood sugar. You take the insulin is the only hormone which reduces blood sugar. Glucagon, catecholamines, adrenaline, name cortisol, everything else increases the blood sugar, because for years and years, for millions of years of this TCA cycle and other metabolism, the source of fuel was fat. And if you see, I'll tell you one more example. If you see, you have got a condition called fat deficiency. Okay, you don't eat fat, there's a fat deficiency. You don't eat protein, you have got marasmus. You don't eat vitamins, you have got beriberi, all the vitamin rickets, scurvy, etc. You don't eat iron, you get iron deficiency anemia. But there is no disease for deficiency of carbohydrate. You have only carbohydrate storage disorders or glycogen storage disorders. So human body does not need any additional carb other than the incidental carb which is present in any vegetable or meat. So you won't get hypoglycemia with low carb diet, because you have got enough hormones to act against the hypoglycemia.
You hit the nail on the right spot, Bruno.
Thank you, sir. Thank you.
Thank you, sir. The next question is for Dr. Shivakumar, sir. Sir, what are the chances for nocturnal hypoglycemia in diabetics who are on intermittent fasting? Because most of the time we would like to have the fasting window during the sleep hours. So what are the chances of them getting nocturnal hypoglycemia, and how can we avoid this?
Everybody has a low sugar, the general physiology, dawn phenomena. Everybody knows that your sugar around 3 a.m. goes down, a little bit of hypoglycemic. And if your hepatic glucose is released in the early morning, it is a normal physiology, and even diabetes is exacerbated. So definitely diabetics who's on intermittent fasting, they may feel a nocturnal hypoglycemia. Okay, there's no doubt about it. Especially as Dr. Bruno said, with the medication, people are on a medication, definitely they will develop a hypoglycemia with the medication, with the intermittent fasting. So you should not try intermittent fasting and this thing with the medication in a diabetes. So all three is a bad combination. So you have to titrate or adjust your dose according to your blood glucose level. You have to monitor that.
Okay, sir. Thank you, sir. And this is for Dr. Vinod. Sir, will running and regular gym training help in reversal of pre-diabetic state? And what advice do you like to give to those in pre-diabetic state?
Yeah. Thanks for bringing up the question. So there have been a few studies that have looked into this. I think one of the most prominent ones was the AHEAD, and I think this was done at Australia. They come one cohort did, and the other one they didn't. Including low-calorie diets, and also exercise, included exercise in their daily regimen. They saw good reduction in the levels, and some of those who were on the borderline, they also had a remission. There are other studies also that show that remission of diabetes is possible with the proper exercise. So in my experience, I could say that out of 4 diabetic patients who have been training, 2 who had borderline blood sugar levels, they were on metformin. Their blood sugar is other 2, they had a postprandial of around 250 or something. They're still only on metformin, but their blood sugar is reduced. Postprandial is reduced. So there's definitely a very good role played in exercise. And I'll definitely say that just dieting or just fasting alone is not enough. There has to be a lifestyle modification. This has also been proved by several studies. They've compared the effect of just dieting. They've also compared the effect of exercise, and they've compared the as well as diet. So the last one has the best effects.
I would like to add something. Hello. Yeah, actually, physiologically, there are 2 large glucose sinks in our body. One is the liver, which usually gives the glucose and gets the glucose back. And the other one is the muscle. Muscle is actually it is the most active ingredient which uses glucose. And once glucose goes inside the muscle, it does not come into the bloodstream. In a diabetic or a pre-diabetic, especially the insulin transporter in the skeletal muscle is defective. And there is a definite improvement in the glucose transporter and the sensitiveness to the insulin by exercise, that too resistance exercise and building up of muscles and aerobic exercise. So there will physiologically itself, definitely there should be a good improvement in diabetes control. As Vinod said, when you start exercising, and weight training at least as much as possible, and cardio training, both should be included in any lifestyle modification as he says.
Yes, thank you.
Okay, sir. Thank you, sir. And this question,
just one point.
Yes.
There is no one solution for diabetes management. Lifestyle modification, diet, exercises, and then if needed, drugs. It is everything together. And intermittent fasting, everything you have to do in a scientific manner, then the control will be quick and the reversal is possible. There is no one magic pill or something like that for this disease.
Understood, sir.
Absolutely. That was the reason we brought all four experts and four topics together. And the question over. And
So we
Vinod,
still
can you
have-
suggest some challenges for our local fitness group? Because
Sure,
we've been debating for the last 2 weeks.
Sir, veda.
We'll start on something mild.
No,
Sir, our people are the other side of the spectrum, sir.
including all the four aspects.
Yes. So the American Heart Association says that we need around 150 minutes of exercise per week. So out of that, 75 minutes should be spent on moderate intensity, and the remaining should be on vigorous. So we could assign like 5 or 6 days a week of moderate intensity exercises like walking or maybe some low intensity cycling. And 2 days, you can try 10-meter sprint combined with walking. So that could be effective.
I think that's
And
doable.
of course, we can include flexibility exercises like stretching or yoga.
Okay. Carry on, Priya.
Yes, sir. This is for Dr. Balaji, sir. Sir, what advice would you like to give for a beginner who wants to start intermittent fasting?
I think Dr. Sivakumar covered it. If you want to start, first thing is you don't find excuses to not start this. And we are a culture where, we always are, you eat this, you take more vitamins, you take this and that. So the concept of that is if you do something, I want to eat chocolates. It's a way of rewarding myself. No, it is not way of rewarding yourself. We are actually poisoning your body with sugar. So what I am trying to say is, first of all, you should decide, I want to do this. And it's very easy. Start with whatever you're comfortable with. Our body is actually very, very intelligent. We are actually foolish. Our body is actually very intelligent. So start with 8 hours of fasting. Go to weekly, 10 days or something like that. Keep a defined this thing and slowly build it up. 3 hours, 4 hours on the Mari. Probably make it to 16 hours of intermittent fasting with about a 6 to 8 hour eating window, which I think will be beneficial. The main thing is beginner, just make sure there are a lot of resources, there are a lot of people willing to help. Talk to them, monitor yourself, make sure you take all the blood tests and the ultrasound test, because most of us think if there is any problem, as Bruno sir said, like you really know, you should know what you're doing at first, make sure everything else is normal in your body, and then start it off slowly but surely. You have to decide, get the knowledge and start.
The next question is for Dr. Shaktish. So what advice would you like to give for an over-enthusiastic beginner who wants to start some fitness activity?
Yeah, that's a very pertinent question to answer for our enthusiastic group. See, actually, as a lot of people have pointed out, workouts are part of the lifestyle modification that is needed to bring about a change. So if these workouts need to be a long-term change in your lifestyle, 3 things are very important. So the workouts need to be enjoyable, it needs to be productive, and it should be, more importantly, injury-free. So then only it will become a lifestyle change. Otherwise, it will be an isolated phase where you do these workouts, and then you just say like the chichi in the palam pulikundra madri, we just move ahead with our routine lifestyle. So for that, you should start. The first thing that we should keep in mind is it should be enjoyable. It should be competitiveness is very important. But in the over enthusiasm, we should not injure ourselves. So the injury-free workouts is the most important thing that we should look for, because we are looking at a long-term lifestyle change. So first thing I would advise is listen to your body. Okay, if your body is comfortable with what you're doing, you can proceed. And another thing is that, it doesn't mean that you ran 2 kilometers instead of your 1 kilometer. See, it's not just about the quantity. It's the way you run that can cause injuries, because many times, if you say, for example, you're doing a calisthenics challenge, and if you're doing an exercise, even 5 repeats of doing the exercise in a wrong manner can injure yourself. So that is what is important. So what we would advise is take the advice of some expert in the field who can guide you how to properly do. If you take running, you have to take advices from somebody who has been doing this for quite some time, and you have to concentrate about the basic running form. That is the most important thing. If you take running, the most important thing for a sustained running is running form. So when I started running, I knew very little about it. My guru, I call him always Guruji. Balaji was my guru. So he taught me basics about how to run properly, how to keep your form. He always used to say, when I said that, once I just called him after cycling, I just told him that my hands got numb after 30 kilometers. He said, you should work out on your core. I thought, see, I was saying my hand is, I thought he will be telling that you buy some gloves and wear it. But he said, you work out on your core strength. So involve somebody who has a knowledge on doing things. So you will get key inputs about how to, properly do a workout. So when you do that, and another thing is you adopt a step ladder pattern. So you bring your intensity of workout to certain level, stay at that level for some time until it becomes very comfortable, and in fact, it should go to the level of being a boring thing. And then you go to the next level and then stay there until it becomes comfortable. So if you adopt the step ladder pattern, you can have an enjoyable, productive, and injury-free workout. So that's what we should be looking at.
Thank you, Dr.
Absolutely, Saktish. I think when I got injured, had a knee problem, Vinod also sent me a video to strengthen the knee and also the core. One of my friend Murli, who's a long distance runner, he sent me a few exercises to strengthen the knee as well as core, because I asked him whether to have a kneecap or something to protect, but instead he said work on your core and strengthen that first before resuming the running or cycling. So it's very important that we understand basic and also have good mentors and people who can really help you out.
Thank you, sir. Edil, you can continue with your question.
There is a question for Dr. Bruno. Do we have to give vitamin supplements for people who are on keto diet?
Yes, madam. Actually, what we have found out is as soon as you change the diet, you are changing the metabolism. Okay. So far, your cells would have been having more of the enzymes and coenzymes dealing with the glycolysis. Now, you are changing the metabolism, means what you are literally doing is you are taking out a petrol engine, taking the parts of a petrol engine, doing some modification, fixing it again as a diesel engine. So when you are removing the engine bit by bit and fixing it again, you will need the washers, grease, etc. Same way, when you are changing the metabolism, if you see the B complex vitamins and other vitamins and especially iron are all either as the coenzymes or as are part of the enzyme or part of the enzyme complexes. So when the diet is changed, there's an acute vitamin deficiency, and it is always better to supplement the vitamins. Else what happens is after 3 weeks, the patient comes with hair loss, hair fall. Because hair follicles is one of the rapidly proliferating cells. And when there is a deficiency of vitamins, especially B complex, etc., the first organ to be affected is the hair. So to avoid hair loss, it is always better to supplement vitamins in the initial phase. As you know, B complex vitamins are water soluble. There is no toxicity. Only if you are giving A, D, E, and K, you should look out for toxicity of A, D, E, and K. B and C doesn't have any toxicity because whatever the high dose you give, it goes by kidney the next day. So it is always better to supplement vitamin B complex and C without even checking any levels. But if you are going to give A, D, and E, K, I would advise to check the levels and then give the vitamins. Vitamins as well as iron, as well as some micronutrients are needed.
That was a wonderful explanation with a beautiful analogy. Next question to Dr. Sivakumar. Sir, is food portion control suitable for diabetics?
Food portion control means you are trying to take the portion, isn't it?
Yes,
Calorie restriction.
Yes.
for a straight away for a diabetic patient, if they reduce calories, it's good for them, because once you reduce the total calories, automatically whatever the component of carbohydrate is going to reduce. So that is going to help in the management of diabetes. So definitely calorie reduction in a patient who is taking on medication on diabetes is going to indirectly help their sugar level. It definitely is going to help.
Okay, sir. Dr. Vinod, weight training and other anaerobic exercises are known to cause increased lactate levels. Do you recommend these kind of exercises for a patient with diabetes or a person with pre-diabetic state?
Yes. So this common misconception that weight training is anaerobic and running and other forms of aerobic training is totally aerobic. But the truth is actually weight training can also be performed as an aerobic exercise. That is, when you use lesser weight, more number of repetitions, then it becomes an aerobic workout. So in a typically, when you have an accumulation of lactate, the main symptoms that you'll have is rapid heart rate and shortness of breath, which will both happen in extremely anaerobic workouts. So this doesn't necessarily have to happen in any form of weight training. So suppose I can load my bench press up to 30 kgs and I can safely lift 12 to 15 repetitions without feeling breathless. Then probably means that I'm not in anaerobic mode. I'm mostly in the aerobic part. So you can actually use weight training as an aerobic exercise. Probably during the last set, when you're trying to go lower on the repetitions, you'll increase the weight. And that is when you'll have a slightly anaerobic component in weight training. So weight training as such is definitely going to be useful for anyone, even if you're on an aerobic regimen. And as such, even if the diabetic patients are advised anaerobic workouts, I think that will also be useful because anaerobic workouts have been shown to deplete glycogen stores. So if you're going to increase your lactate levels, there's definitely going to be overutilization of muscle glycogen. And the next phase, the next source of energy would be the blood glucose. So which will lead to reduction in glucose levels. So eventually the diabetic patient will benefit from anaerobic exercise. We just need to make sure that nothing adverse happens.
Okay, sir. Question to Dr. Balaji. What is the ideal food to break the fasting in intermittent fasting? Can exercise be done during the fasting window?
Actually, intermittent fasting, the breaking of it is not, you can eat your normal diet actually. Only in extended fasts, the practice of breaking actually comes in because your gut biobacteria is actually different. At that point of time, it's usually recommended to have good fiber, a source of lean protein, especially eggs. If you're a non-vegetarian, you can probably take bone broth. If you're a vegetarian, you can take broth and follow it up with eggs. But in intermittent fasting, which is about only 12 to 16 hours, you can take your normal diet in 8 hours. Only when you're fasting more than 48 hours, usually the breaking of the fast needs to be very careful. And exercise during fasting, definitely you can do. Actually, it's more beneficial. But the key to exercising is moderation in it. You cannot go work out weights very, very badly, or you cannot do any extremes. Just make sure you're in a very relaxed run or a walk or a mild weight training exercise. As you get used to it, you will probably be in a better state of mind, but definitely you can exercise while fasting.
Okay, sir. Question to Dr. Bruno. How long can a patient with diabetes follow a keto diet? Can you please list out the absolute or relative contraindications for keto diet?
No, madam. The point is he or she has to follow it as long as the keto diet is required to keep his blood sugar under normal values. So, suppose, as I said, say someone is having a weight of 130 kg, there will be definitely a hyperglycemia because the insulin which is secreted will be sucked out by the fat tissues, and there won't be any insulin in the skeletal muscles and the other tissues. So such a person, even with a normal pancreas function, will present with elevated fasting sugar, elevated HbA1c, and then say elevated postprandial. Suppose that person follows keto diet for say 18 months to 24 months, and brings the weight to 84, then surprisingly you will find that even if he eats jangris and idlis, the sugar will be normal. So such people can stop the diet after 18 months or 24 months. But what the side effect is, once he stops and goes to a full carb meal, the weight will increase further and then the sugar will increase. So essentially, we have, instead of having any fixed targets, what someone should work out with this, you have to consider this as a treatment process. And if you need, you take it. Some people may need it for lifelong. Okay, the example I give to patients is, na paranga mudi narachitna dye adikano. கடைசி வரைக்கும் நான் அடிச்சுட்டு தான் இருக்கணும். உங்களுக்கு பீட்டா செல் வந்து நரைச்சி போடுச்சு, அதனால டை அடிக்கிறதுக்கு பதிலா டை அடிக்கிறதுல 2 ஆப்ஷன் இருக்கு. ஒன்னு அரிசி சாப்பிடாதீங்க, கோதுமை சாப்பிடாதீங்க, இல்ல இதை சாப்பிட்டீங்கன்னா மாத்திரை சாப்பிடுங்க, இல்ல கொஞ்சம் வந்து டயட்ல கண்ட்ரோல் பண்ணிட்டு கொஞ்சோண்டு மாத்திரை சாப்பிடுங்க. ஸோ ப்ராப்பர் அப்ரோச் taking into consideration the patient's socio-economic conditions will work. பட் ஸ்ட்ரிக்டா நான் இதுதான் சார்ட், நீ காலையில இப்படி சாப்பிடணும், மத்தியானம் இப்படி சாப்பிடணும் அப்படின்னு சொன்னா they quit in 3 to 4 months.
No, many diabetes educators give a long list of food and ask them to follow this. 100 grams, 50 grams, 1 teaspoon, 5 ml, all those kind of. Does it work in the long run?
No, it doesn't. It never works, sir. We essentially, sir, நம்ம ஃபுட் அப்படிங்கிறதுல வந்து நிறைய கான்செப்ட் இருக்கு சார். ஃபர்ஸ்ட் வந்து there is a taste component. Okay, you reduce the taste too much, the patient will discontinue. Second is a cost component. இப்போ இன்னைக்கு வந்து ஒரு வீட்டில் சாப்பாட்டுக்கு 4000 ரூபா ஆகுதுன்னா 4500 ரூபா ஆகுற மாதிரி ஒரு டயட் கொடுத்தீங்கன்னா தான் அவங்க ஃபாலோ பண்ணுவாங்க. நம்ம பாட்டில் 8000 ரூபாய்க்கு ஒரு டயட் சார்ட் போட்டு கொடுத்தா 2 மாசத்துல காலியா போயிடும். Third is especially in middle class, the most important factor is time to cook. இப்போ poor வந்து look at the cost of the food, rich look at the calorie of the food, middle class looks at the time to cookம்பாங்க. So time நம்ம the
time to eat also,
time to eat also, cook also. So நம்ம வந்து எப்படின்னா நம்ம when you are giving a lifestyle modification, no, this is not like typhoid where you are going to advise a diet for 2 weeks. You are looking at months or years. So when you are giving a lifestyle modification, taste ரொம்ப affect ஆகக்கூடாது, காஸ்ட்டும் ரொம்ப கூடக்கூடாது, and then டைமும் ரொம்ப கூடக்கூடாது, பட் சுகர் நல்லா குறையணும், வெயிட் நல்லா குறையணும். இந்த மாதிரியான ஒரு பேலன்ஸ், you have to balance the sugar levels and weight on one side and taste, cost and time to cook, time to get the raw materials, anything on the other side. அப்படியே ஒரு பேலன்ஸ் பண்ணி பண்ணுனா there will be a long compliance. There are people who are following it for 12 to 14 years, follow பண்ற பேஷண்ட்ஸ்லாம் இருக்காங்க. And but if you are very strict, they will quit in 3 months to 4 months.
Okay, sir. Are there any contraindications for keto diet, sir?
Contraindications, as we already discussed, madam. Say if the keto diet increases the LDL, okay, you give statins. If there is some other problem, say வந்து already வந்து urea 80, creatinine 3 ன்னு இருந்துச்சுன்னா, don't take the risk.
Thank you, sir.
Edil, there are a lot of questions posted in the chat box. I think Bruno sir is already replying the questions. Audience who are
I think there are a few questions for Vinod and Shivakumar also. You can take one by one. Yes. And also we can open up the, we can unmute the audience and ask them to unmute themselves and ask questions. If you have completed your questions, we can open up the audience box.
We got few questions.
And there's one question which, what will happen when patients with peptic ulcer? Nothing will happen. In fact, it will even heal because most of the ulcer is caused by a high carb diet.
Exactly. In fact, one of my patient gave a testimonial that his GERD problem got solved after taking this LCHF diet.
Yeah, that is very simple physiology, sir. One of the cause of GERD is an increased intra-abdominal pressure. Okay, when there is an increased intra-abdominal pressure, what happens is the stomach gets an external pressure and the food is forced into the esophagus. This increased intra-abdominal pressure is due to excessive fat in the retroperitoneum, excessive fat in the peritoneum, excessive fat in the anteroabdominal wall. When the keto diet, when the fat in the extra retroperitoneum, peritoneum, and anterior abdominal wall reduces, the amount of pressure externally over the stomach reduces, and the GERD also solves.
Okay, sir.
So there's a question for Dr. Vinod Nathaniel. What is the magic formula you follow? Is it just exercise or other things too?
Yes.
The most wanted question, Vinod.
Right.
Hard work, hard work.
That's experience. I can definitely say it's not just exercise. Definitely diet plays a huge role. So initially, when I started out on this journey, I thought as long as I'm running, I'm fine. I'll be fine. So I don't have to diet. So this is the mistake that almost everybody makes. So we think that running burns really huge load of calories, so we can have whatever we want, and we actually forget the value of a calorie. So we think that all calories are equal, whereas the calories that come from a burger is going to be different from the calories that you are going to get from a highly nutritious source. So these two are definitely going to differ. And when I started running without dieting, I noticed a lot of changes, like reduced attention span during work and more source of irritation. So all these started happening when I didn't pay attention to my diet. But when I started to eat clean, made the right choices, reduced junk food, and made sure the same calories came from healthy sources, then I noticed that my mind started functioning better. I had lesser bloating issues. I could think better at work. I could perform better. I could speak and explain to the patients properly. And of course, this eventually reflected on my exercise sessions. Also, I was able to run faster with a lesser injury rate. So definitely, I'd say that it's not just exercise. Diet plays a huge role, and of course, sleep. I make sure that I switch off my lights at 9:30. If I switch off my lights at 9:30, I can sleep by 10:30, and only if I sleep by 10:30, I can get up at 5. So when I get up at 5, I can have time to work out, or from 5 to 5:30 to 6:30, or up till 7 o'clock, depending on the regime that I fix for the day. And when I work out, the rest of the day falls into play. So that's how it goes.
It sounds very simple, but it's very, very difficult when you're a practicing doctor.
Very true. That consistency is the main thing.
Yeah.
Sir, is there any way to improve HDL without supplements if suppose unable to do adequate workout?
No, I think I answered it detailed in the chat box itself. So this is another common misconception which our people have is they consider that taking a treatment, especially taking a diet, as something less courageous, and trying to solve the problem without taking a tablet or doing a surgery as something more courageous. So such things won't work in the long run. The primary goal is to avoid complications of diabetes. So whatever is the best method we have to do. If you need tablets, you need to take tablets. If you are able to have a normal HDL with without tablets, well and good. But the goal should not be when you start itself, you should not look at excluding a treatment and then looking at the choices, by which we will eventually leave out what is the best mode of treatment. So if your body, if your genetics, if your various enzymes are all functioning good, you don't need B complex to have a good HDL. But if there are some inborn errors of metabolism, actually there are lots of inborn errors of metabolism in these pathways which do not express because they are in the recessive genes. So, but when you are putting them under the stress, they will have some, they will create issues. So if there is a problem, you take B complex. Most of the inborn errors of metabolism in fat metabolism gets solved with B complex, because the coenzymes of many of the enzymes are B complex vitamins only.
This is for Dr. Shaktish. Sir, can you suggest and advise selection of shoes and sports accessories?
Yeah, that's another very important thing. See, it's a kind of continuation to the previous question. What are the things that we should focus when we are starting out on a fitness journey? So the gear that we use is very important for the all the other things that I mentioned, like for it to be pleasurable, for it to be productive and injury free. So many a times what we do is when we start out running, see, I'm just starting out on my fitness journey. What we will think is I will start out with whatever shoes that I have, and I will start out with whatever cycle I'm able to find out. So, but what that can lead on to is like if you are running on an inappropriate shoes, which is not comfortable, which is not simply suited for the track that you are running on. So definitely your fitness journey will be cut short because of the injury and other pain that you will get because of the gear. So once again, take expert advice from people who have been doing this for some time. So there are a lot of shops, fitness shops that offer, when you go to them and when you say what you're going to do, say if you're going to run for 5 kilometers per day, there are people in that shops who can guide you with selecting the right kind of shoes or shoes for you. So try them out and, don't think about the investment. So many times what we say is, I will buy a good shoe once I start doing this regularly. But why you have to see it from the other way. So you consider this investment in a good shoe as a motivating factor. See, if you buy a shoe for say for 9,000 or 10,000, that can serve as a motivation to run daily. So that is the way you have to see it. And as far as cycle goes, see, it depends upon your comfort level. Most important thing I would say is you just go for the right size. So once again, the people who have been doing it can guide you. So if we buy a wrong size cycle and you ride it, definitely you're going to land up in back troubles and other things, and which will ultimately result in you stopping up the workout, thinking that you are not strong enough to do that workout, while it will be actually the gear that is at fault. So definitely take people's advice, explain the shop people what you're looking at, and definitely they can guide and help you and buy the most comfortable one, even if you're starting.
I will add 2 points. So when you are starting to walk, don't worry about the shoes. You walk with your normal slippers for 20 minutes, at least for 1 week. Or if you are going to want to cycle, don't immediately, there is no need to buy a cycle. Just use the normal hero cycle or whatever cycle is available for 1 month, daily 15 to 30 minutes. And if you are very comfortable with that, then you can invest on a new cycle. Because what I have seen is lots of people buy fancy shoes, fancy cycles, and don't use them after 1 week. And then this motivates the next person who sees the cycle and shoes lying unused. He doesn't even start it. So walking can be all the well started with the normal slippers. At least for the 1 week, start 20 minutes. I don't think you need a special shoes to walk for 20 minutes. Then if it is comfortable, by 20 minutes, what happens is the body forms a rhythm and you'll be an addict. Exercise is one of the most powerful addicts. And once you get into that addiction, then buying this fancy gadgets will help. This is my personal opinion.
No, sir, I would like to slightly differ on your opinion. See, actually, you are the most enthusiastic when you start out. So when you start out, you tend to actually push yourself hard. So most of them will not start doing 20 minutes or 15 minutes. They'll always start with a 1 hour, and then it will go a downward journey because of the injury. So what I would suggest is, if you have a commitment to, it is like all or none phenomenon. So if you don't have commitment, you should not be taking. If you are clear that you want to, it should be a lifestyle change. If you are thinking about lifestyle change, you have to pick up the right gear and start it in the right manner. So testing out, like it's like a smoker saying that I will reduce my cigarette numbers and then I will try to quit. He will never quit. So that is the thing, that it is an all or none phenomenon. If you want to do it the proper way.
I'll just add a small rider to it. I agree with both Dr. Bruno as well as Dr. Saktish. But when you start an activity, expect some aches and pains. முதல் நாள் நீங்க போய் வாழ்க்கையில நடக்கவே நடக்காம ஒரு 1/2 hour 45 minutes போனீங்கன்னா டெஃபினட்டா கால் வலிக்கும். அதுக்காக அடுத்த நாள் காலையில வந்து does not mean you have to stay in the bed. You have to make an effort. Same day
Independence Day marathon வந்தா வலிக்கும்.
அதுதான். See, you should moderate it. You should know which pain is good and which pain is bad, and then keep the enthusiasm. Same way, when you're starting an intermittent fasting, பசிக்கு தான் செய்யும். பசியே இல்லாமலாம் இருக்காது. அதை you have ways and means to go through it. So initially, you should get over the stage and apply common sense to it.
Yeah, see, you should differentiate between pain and injury. See, pain is okay, but injury is what we are concerned about.
There's one question for Siva. Do you feel hungry when you are on continuous fasting?
Regarding hunger, everyone knows the girl is hunger hormone. Hunger hormone is going to continuously increase to the extreme level. After 3 hours of eating, if you feel hunger, the ghrelin will increase. If you don't give any food, the hunger will come down, the ghrelin will come down. It is a cyclical phenomenon. So there is no continuous increase in hunger. You have noticed many times when you are busy at work, feel hunger, not able to take anything, then it gets over after 1 hour. That is a simple hormone. So when I'm on a long fast, maybe after 2 or 3 days, I don't feel hunger at all. The problem for me is, especially when I go beyond 5 days, I don't feel like breaking it because I can work very well with my brain, and a lot of time is free. Eating time, you know, that other restroom time, and sleeping is perfect, fantastic. I can just go to sleep immediately after. All this happens after 5 days. But initial 2 to 3 days, you will have a little bit of hunger pangs, and if you take water, this subsides. But in a long fasting, what I observed, not even for me, everyone, when you feel hunger, the body is asking for micronutrients and some other nutrients and water. So my perception is hunger is it's water. Number one, when I feel thirsty, the dry mouth, the body is asking for electrolytes, sodium. Even today morning, I felt thirsty. I kept 2 spoons of table salt. I gulped it. Immediately the dry mouth has gone away. But when there's a dry mouth, if you drink water, you will not get better. So the hunger is not going to be continuous. Especially after 5 days, you will not feel any hunger. Even today, I'm not feeling hunger. The problem is when there is a feeding after long fasting. That should be a problem. So there's no hunger. And I could see some other 2 questions for me in the chat box. One is about 5 is to intermittent fasting. That is promoted by Walter Longo. That is simply I'll tell you, 5 days you eat a normal diet, normal calories, and 2 days in a week you take only less than 500 calories. There is a lot of research, lot of benefits, so many things are being told in that fight to do intermittent fasting. But those who are not able to do a regular daily intermittent fasting, they can try that first. But that is, then they can feel the experience, and then they can go for the full day water fasting. There's a question answer for the this thing. 5 is to intermittent fasting. There was one more question about when you are taking only water. For intermittent fasting, I mean, in the fasting period, what are all allowed? No calories. That is black coffee without sugar and milk, black tea without sugar and milk, green tea. All these things are allowed theoretically. But practically, even if you take 30 calories, it's 10 calories, it's okay. So when you are on a fast, you can take a lemon salt water. Because what happens when you are doing fasting, people mostly get a giddiness. It is not because of hypoglycemia. It is because of hyponatremia, low sodium. Why it happens? When you are not eating, your insulin goes down. The main function of the insulin in kidney is reabsorption of the sodium and the water. The moment you stop eating, the insulin goes down. Because of the low insulin, you are peeing out a lot of sodium and water in the urine. So you get a hyponatremia, hypovolemia. So you have to fill it with the water. If you take only plain water, again you are diluting your sodium. Again you will have a problem with the hyponatremia. So you have to always take electrolytes. In Western countries, we have a composition of sodium, potassium, and magnesium. Ready-made packets available, solution available. But India it is not available. So I have found a small formula. It may be useful to everyone those who are trying out the fasting. Vegetable broth. Because when I do a long fast, I take a vegetable broth. The recipe is available in the YouTube, and there's a slow cooker available. So vegetable broth definitely doesn't have any calories. It has a lot of minerals, not only sodium and potassium, even magnesium it has. Another important problem in a long fast or intermittent fasting, you'll have a low magnesium. To avoid low magnesium problem, the best route is not taking oral. It's a transdermal application. Normal Epsom salt, very low cost. I used to apply every day in the leg before going to the bed 2 hours, 3 hours, and then I wash and then go further. And when I'm doing a long fast, I take a vegetable broth. I take a Epsom salt bath. I mean the leg application, and I take a black coffee. So I restrict my black coffee only in the morning. After 11 o'clock, I don't take a coffee. I may take a tea because everybody knows that coffee will affect the sleep. So I give more importance to sleep than my fasting. So during fasting, you will not have a hunger, number one. During fasting, you can take black coffee, green tea, or black tea, or a little bit of lemon salt water. That's all you can take. In
what about the fruit infusions, Siva?
Fruit?
Yeah, infusions with fruits. It's not the juice. With
real fruit.
Vegetables.
Real fruit.
Yes.
See, the one of the major culprit, major poison is fructose. Because if you take a glucose that can be utilized by cell as energy, if it is not able to utilize by the cell for whatever the reason, it can be stored as a glycogen. Later on can be used. If it is not stored as a glycogen, it can be stored as a fat. Later on can be used. But the fructose, there is no way in the glycolytic pathway. Unless otherwise the glucose goes zero, then only your fructose will come into the ATP. So, but the glucose will not go down. Even now I'm on a 10th day fasting. If I check my glucose, it will be approximately 50 because the body can produce gluconeogenesis from whatever the source available. So that no time the glucose is going to zero. So the fructose which is in the body will be stored as only fat. The maximum reason for fatty liver, non-alcoholic fatty liver is, my perception is fruits, that's fructose, any form of fructose. And people say fruit has a lot of nutrient, fiber, and minerals. But if you compare on a Google, you see a comparison between fruits and vegetables. The vegetable has, all vegetables has a more fiber, more nutrient, more phytonutrients, more minerals, more vitamins than fruits. And the fruits comes with the poison of fructose. But because why we are taking fruit, whole fruit, or one day fruit, because of the sweetness. Our tongue is addicted to sweetness. As Dr. Bruno told, it's a taste and condition. Because of that only everyone is taking fruit. I never taken fruit for last 5 years, except blackberry and strawberry and some of the thing. But definitely you can be without fruits. There is no need for a fruit, as far as I understanding, my understanding, and I'm concerned.
Sivan, my question is not about fruit juice or fruit.
Okay.
It is about fruit infusion, infused water with just to have the flavor of the fruit.
That is artificial. I don't know anything about that. Fruit.
No, like you take lemon water and tea or green water. Just to make it interesting, the fruit infusion. So many people suggest that fruit infusion gives an alternative way of hydrating yourself without giving the calories.
Yeah. If there's no calories and no fructose, you can take it, I think. But I don't have any personal experience on that.
Okay.
One last question for Sivakumar sir. So do you believe in switching over from normal rice and pulses to brown rice and millets?
Dr. Bruno has told it clearly, all rices and all meat, everything is bad. So I never take rice. I not taken rice on a regular basis, but for a metabolic switching, metabolic flexibility purpose, and for my own testing purpose, I used to take once in a month, because in our family there's rituals. I mean, Amavasa Vradam. அன்னைக்கு வந்து நான் வந்து கண்டிப்பா ரைஸ் சாப்பிடணும். பட் அன்னைக்கு கூட வந்து எனக்கு வந்து ஒரு கரண்டி 2 கரண்டி ரைஸ் தான் இருக்கும். ஈவன் அது நான் எடுத்தா கூட என்னோட சுகர் லெவல் ஸ்டாட்டிக்கா தான் இருக்கும். பிகாஸ் ஐ டோன்ட் கோ பியாண்ட் தட். ஃபார் ஸ்பிரிச்சுவல் இஷ்யூஸ் ஐ டேக், not for energy purpose, not for the nutrition purpose. Because as far as me concerned, the energy, even food, I think it as a nutrition and energy. And the nutrition, I think it as a macro and micro, protein and vitamin, minerals. And energy, both fat as well as carbohydrate are energy component. So I don't take much of energy component. I concentrate more on the nutrition component.
I think we can go on endlessly discussing about these issues.
One thing,
we have to
I want to say one thing, Nirmal. Actually, yes. I must thank Dr. Bruno, because in 2016 September, I met him for my consultation of paleo diet in a GG hospital. I did a lot of tests with the ThyroCare, and I met him, and then he said the same thing. He has given a concept. He has given in own writing, all color pens, and then I have that. That's my first consultation with the neurosurgeon for a paleo diet, and I started that. And then I attended PaleoCon July 1 in Coimbatore. That also I listened to your talk. And another thing, Dr. Vinod Nathaniel, after seeing his YouTube video, I asked him about the gadgets. He immediately replied with the Garmin gadgets. Thank you for both of you, sir.
Thank you, sir. I will just add 1 minute, one final minute. Actually, the concept of wheat is better than rice came out 40 years ago, when the complication you wanted to avoid was DKA and HSS. Okay, so rice produces a big spike, whereas wheat does not produce a spike but has a sustained release. Now, if you see, when you want to avoid DKA and HSS, you need to avoid the spike. But what really happens is the chronic complications due to advanced glycosylation, end products, etc., depend upon how long your sugar level is more than 120 milligrams in your blood. So if you compare between rice and wheat, rice has more chance of getting a DKA, but wheat has more chance of getting your heart coronary arteries blocked. This is just in one word, because in wheat there is no spike, but the amount of minutes the blood sugar is in the range of producing microvascular and macrovascular complications is very high in case of wheat rather than rice. So today I don't think we have DKA unless someone is very erratic and does some rubbish treatment. But what we are trying to address today is the long-term complications. So for the long-term complication, wheat is either as dangerous as rice or even more dangerous as rice. So avoid it. No, you come to low carb totally.
That's as emphatic ever, and the same Bruno in battle combat format. Thank you, Bruno.
Thank you, sir. Thank you.
I think we have to conclude.
Yes,
the moderators to ask the maybe last question to all the panelists and speakers.
I have a personal question, sir. Sir, Dr. Bruno and Dr. Shivakumar, both of you said that it is better to avoid as much as fruits as.
Yes.
If at all we have to take a fruit, would you suggest any of the Indian fruits, like something like guava, papaya, something like that, sir?
No, madam. What if at all you need to take a fruit, take it in a low amount, low quantity.
Okay, sir.
Okay.
Or you can send the fruit basket to all of us.
That's even more better.
That's very bad, sir.
Okay, maybe one or two tips, short tips from each one of you about on your topic. Starting with Bruno on LCHF.
Yeah. Okay. The simple point is just to understand the concepts as a doctors, it is nothing to be frightened. So the one concept you need to understand is eating fat does not produce fat in the body. Eating carbs produces fat in the body. That's one concept you understand. Second is, this is a scientific diet and it can be tailored to your need or to your patient's need. Don't go by prefixed diet charts or prefixed concepts, prefixed things in the YouTube or some things written by Western authors. Just understand the science and you can follow it gradually and in a very relaxed manner.
Okay, Shiva.
As Jason Fung says, fasting is the best diet because all our religions are following one or other form. Any religion, any region, any country, any place, they have a one or other form of a different form of fasting. Why they have in a community, civilized community, they have a fasting in different type. My understanding was when there was a Paleolithic era, nobody had a regular 3 meals a day. So whenever they got the food, they have to eat. Other times they have to be on fasting. So, but when they civilized by the agriculturing, they must have had some problems of eating all the time. So they must have found the observation and not eating is the a treatment. That's why they suppose if you say straight away don't eat, nobody's going to follow. Because if you put it on some kind of guidelines for some maybe some community, some religion, then people are going to blindly follow that, the faith on the God or something like that. That's why they have developed a spiritual aspect fasting. So based on that, definitely everyone will benefit because of any type of fasting. So anybody can do a fasting. Scientifically also, I shown a lot of articles. And spiritual also, our ancestors also did some lot of fasting. So no one to hesitate to start fasting. If there is any questions regarding fasting, I'm always here to help in a personal manner. Thank you very much, everyone.
Thank you, Siva. Yeah, food itself is evolving along with mankind. So right from Neo-Paleolith and Paleo diet. Vinod, over to you.
Sir, your audio is not clear.
Yeah. So fitness as such, I think many people they get apprehensive when they hear the word fitness. But actually what basically fitness means is you should be fit enough to perform well at work and to accomplish your goals on daily. So to do this, we just need to perform two simple types of exercise. One is aerobic and other is anaerobic. So anaerobic, nothing to be worried about. You just need to strength train twice or thrice a week. And for the aerobic part, you can start with walking, probably like 1 or 2 kilometers daily. Then you can slowly build up on that. Usually recommend like starting out with around 20 minutes per day. Then slowly you can improve to around 45 minutes. Usually recommended is 45 minutes of aerobic workouts. And strength training twice or thrice a week with flexibility sessions like stretching or static stretching. That should be done around 5 or 6 days per week. Of course, you have to eat healthy. And as I said, probably fast once or twice a week. Whenever your workouts are going to be less intense, you can fast 1 day previously. So all this will definitely help.
Satish, and
sir,
then the
Siva sir results irukingla?
Somebody is asking me to show the sugar level and ketone level. If it is ready, I can just demonstrate now. It's just, I'll take 5 minutes. I'll just demonstrate. Is it okay?
Yeah. Sure.
So this is
nice to see Ayyappan here. Thanks,
yes,
Ayyappan, for joining. And a lot of Vinod's fans are also here.
Is it clear, the machine?
Theriyala sir, theriyala.
You can read it, Siva. Some numbers are there, but not clear.
It says 73.
Right.
Oh.
And I'll show you this thing. Ketones, 1 minute. It says 5.1. I'm on nutritional ketosis now. So 10
Sir,
days
73,
not 73
73 after
glucose.
how many days?
10 days.
10 days.
10 days.
10 days
Today,
not
10th
eating.
day.
Okay.
Almost 240
Okay.
hours.
So you are not dead because of hypoglycemia.
Yes. And my ketones
Obviously.
are 5. My ketones are 5.1. Still I'm active. I'm not into ketoacidosis. So people always confuse with the ketosis and ketoacidosis. I'm in a nutritional ketosis. If it goes beyond 6 up to 8, it is a starvation ketosis or fasting ketosis. Beyond 9, then only you will get a diabetic ketoacidosis, provided your sugars are high, your insulins are low.
Right. It's amazing, Siva. Your wife must be very happy because no need to cook for you.
No, but on cooking day, she has a terrible time because she has to cook to my specifications.
Okay. I think last few words from the moderators and panelists. Our treasurer is eagerly waiting to propose the vote of thanks. Yes, Satish.
Yes, sir. See, as it has been summarized already, see, for remission and reversing diabetes, so the most important thing is regulating your BMR. See, the BMR consumes the most of the calorie expenditure of the body. For you to have a good BMR, the most important thing is to have, a good muscle mass. So that's why we advise exercise and workouts, because the muscles consume most of our energy. So you should have workouts, and definitely it is not just about workouts. You should have a good diet, some kind of diet which is comfortable to you. Either it could be a time restricted diet or a keto diet which is comfortable to you. So diet is another pillar which is important for maintaining a healthy body BMI. So all these things, see, you have to maintain your BMR by doing both workouts and diet. Both are equally important. That should be the take home point, and it should be a long term lifestyle modification. It should not be a short thing. You should be motivated, and you should include this in your day to day life.
From the two moderators,
Yes, sir.
you have a lot of take home points and a lot of work to do now. Write up all the carry home messages and share in the group.
Definitely, sir.
And also for our newsletter.
Sure, sir.
Yes, sir.
It's up to you, two of you, to close the session.
Yes, sir. We are happy to express our sincere gratitude to all the panelists who spent their valuable time on a Saturday evening. The program got extended. We just said 1 hour, but it went on and on. Very interesting session. Thank you so much to each one of you.
Thank you for the opportunity.
Thank you, Bruno. Thanks for joining. Thanks, Vinod.
Thank you, Dr. Bruno.
And over to you, Dr. Karthikeyan, our Finance Secretary, for the official vote of thanks.
Okay, maybe a lot of thanks is already poured in. Anyway, I'll add up. It was a highly informative, very useful program with a lot of practical points pertaining to fitness, health, diabetes. Really, it was so amazing to see all the speakers, their experience and expertise getting shared. My sincere thanks to all the speakers for their enthusiasm and patience to answer all the questions till the end of this program. Sincere thanks to Speaker Dr. P.K. Jayachandran, and with under the panel discussion titled as Remission and Reversal of Type 2 Diabetes, Dr. Bruno and Dr. Sivakumar has shared their experience and expertise. It was really wonderful. And thanks to all the panelists, Dr. Satish, Dr. Balaji, Dr. Sivaprakash Srinivasan, Dr. Vinod Nathaniel, all of them did a wonderful job. My sincere thanks to the moderators, Dr. Sripriya, Dr. Elarasi, who made this program very lively and so interactive. Thanks to all the participants. Today, the total participants has crossed, it was fluctuating for a long time between 98 to 100, which is quite unusual for any IMA program. That shows how much the traction this program had among the participants. Thank you so much for your patient listening and your valuable time. Thanks to Novartis for their support to make this program successful. Thank you all. Wish you a wonderful, enjoyable weekend. Thank you.
Thank you.
Thank you. Thank you.
Thank you, sir.
Our youthful chairman was missing. I asked him to unmute and put his video, Dr. Selva Ganapathy, sir. Okay, we'll close the portal. Thank you.
Thank